Hello everybody, greetings from IMA New Delhi branch. I am Dr. K.K. Agarwal, past National President, Indian Medical Association. This is going to be a series of orations given by IMA New Delhi branch. This program will be live on multiple social media platforms. The idea is for large number of people to get benefit out of it. Now this is our for us, it is 1906th edition this year and 42nd IMA New Delhi branch meeting. And this is our third oration. We gave a Dr. Rajiv Khosla oration, and then we gave Dr. KL Chopra oration. Now this is Dr. J.J. Sood oration. J.J. Sood was our mentor. Whatever policies and philosophy we are following in this branch has been initiated by a Dr. J.J. Sood. He was a pathologist. He had served the IMA at a national level as a Secretary General. And he was one person who always took people together. And he was responsible for me. जब मैं IMA न्यू दिल्ली ब्रांच में था तो एक बार बोले बेटा DMA के लिए ट्राई करो. So he was the person who instigated DMA के लिए ट्राई करो. ना मैं DMA के लिए ट्राई करता ना मैं IMA का प्रेसिडेंट बनता. So this was 2004 when he told me कि DMA के लिए ट्राई करो. So over to the Delhi branch team, I hand it over to Rajiv Garg, Dr. Vanita Arora, and Dr. Sanjay Dhawan to conduct the meeting.
Thank you very much, sir. Thanks everyone this morning for coming here and joining us in this meeting, and good morning and namaste to all. On behalf of IMA New Delhi branch, today we'll be having Dr. J.J. Sood oration, and in addition to that, we'll also be talking about having a small conference on the recent advances in ophthalmology, especially what the other specialists and general practitioners should know about what is happening in ophthalmology. See, every branch undergoes rapid changes in technology and treatment protocols and the clinical management. So we need to keep abreast of not just our own branch, which we always do, but also we should know about the other branches too. So here the idea is to highlight the changes which are relevant for other specialists to know about ophthalmology. We have had a session on cardiology in the past, which was very, very enlightening because there are a lot of changes which have happened in cardiology in the past few decades. And we learned a lot from there. So today we'll be talking about ophthalmology. And I request Dr. Vanita Arora, our president of IMA New Delhi branch, to say a few words.
Thank you so much, Dr. Sanjay. I welcome you all. Especially, I am so humbled and touched to see Dr. Khalilullah. Professor Khalilullah is amongst us. He's agreed to be here on Sunday morning for this oration. Sir, thank you so much from the core of my heart. It's a pleasure meeting you here, sir. And I welcome you all to this meeting today. It's, as Dr. Sanjay said, an oration as well as the recent advances which we are going to learn about ophthalmology. Sanjay has taken a lot of pains to bring this program together, and I'm sure you all will benefit from it and learn something more, because I, as a cardiologist, don't know anything about ophthalmology. So I told Sanjay, let me learn some things from you all and know more about ophthalmology. So all the best to you, Dr. Sanjay Dhawan, and over to you, Dr. Garg. Dr. Rajiv Garg, please.
Good morning to everyone. Greetings from Jammu. I am in Jammu. So we are going to start Dr. J.J. Sood oration. Dr. J.J. Sood graduated from Government Medical College, joined the first batch in 1948. He was Bhishma Pitama of IMA New Delhi branch. He devoted his life to serve the society selflessly. He was benevolent, kind, philanthropist, humanitarian. The oration is in his name will be chaired by Dr. M. Khalilullah and Dr. K.K. Agarwal. Before we start, I will request Mr. Vaneet Sood, his son, to say a few words, and after that, Garima Sood to say a few words before we start the oration. Mr. Vaneet Sood, are you on the line? Vaneet Sood and Garima Sood.
I'm on the line. I can begin.
Yeah, please speak on.
Yeah. Thank you very much, Doctor. So greetings to all. My name is Garima Sood, the granddaughter of late Dr. J.J. Sood. So just it's indeed a proud moment for us. And on behalf of Mrs. Kamla Sood, my grandmother, and the entire family, we would like to thank the Indian Medical Association for this honor and for remembering my late grandfather, Dr. J.J. Sood. His achievements, his contributions, his guidance, his contributions in the medical field, his philanthropy, his oration skills have always inspired me, and they continue to inspire me. And we are forever grateful for this honor. And we're grateful that his work continues to be remembered, and hope his legacy continues. So thank you very much, and looking forward to the event going forward. Thank you very much.
Thank you, Garima. And we have Dr. M. Khalilullah, a very close colleague of Dr. J.J. Sood. He also graduated from Nagpur. So I will hand over the mic to Dr. K.K. Agarwal and Dr. M. Khalilullah to take over for the oration, which is by Dr. Chawla, Associate Professor of All India Institute of Medical Sciences. Over to Dr. K.K. Agarwal and Dr. Khalilullah, please.
डॉक्टर खलीलुल्ला सर, आपको अनम्यूट करना होगा.
Sir, kindly unmute yourself. Dr. Khalilullah, sir, you have to unmute yourself, sir. Sir, please unmute. Yeah.
Is it okay?
Yes, sir.
Yes, sir. We are able to hear you, sir.
Thank
Good
you.
morning, sir.
Thank you very much, Rajiv. In fact, it's a great pleasure to be here with Varida, the president of the New Delhi branch, a close colleague and aspiring personality in the field of electrophysiology. And with KK around, who is synonymous with the leadership in medical profession, not only in India, but in fact, all over the world. Let me tell you something about Government Medical College Nagpur. It is one of the oldest medical colleges in India, established in 1947. And it was started in a barrack to begin with, then moved to the current position in the medical college campus. It was a sprawling campus of 100 acres with huge lofty buildings and lecture halls. And we were the first, we were the batch in 1956 to be admitted to the great medical college. Now, in this, we had a great department of physiology, which was presided over by the professor head, Dr. Vaishnavi, and Dr. Khandare was the reader, and then Dr. J.J. Sood was the lecturer in physiology. He was a great teacher par excellence. He was very friendly and was available to the students for any doubt, any problems which they had. He moved out from Delhi from Nagpur to Delhi and became a very important figure in the medical circle, not only medical, but medical social circle. He was a pioneer in establishing several things in the IMA, and also was responsible for establishing the Lions Heart Institute. Lions Cardiac Center was established by him. It was a sleepy little clinic to a very active and vibrant institution. His contribution to the field of medicine is enormous. He has great sense of leadership, an extremely magnetic personality. So if you meet him once, you would never forget him. I'm sure his legacy will continue for a long time to come, not only through IMA, but also, see, my whole training was in physiology, which is done by him. And in the basic of medicine is physiology. The whole thing, I got trained in medicine, MT medicine and DM cardiology, and then electrophysiology. Basic was physiology. So I can salute to his memory for wonderful teaching which he had done and great contributions to the field of medicine and to social media and to IMA at length. I'm very grateful to Rajiv to invite me for this great oration. It's going to be delivered by Dr. Rohan Chawla, who is the Associate Professor of Ophthalmology at the All Institute of Medical Sciences. He's going to talk on diabetes and the eye. Very, very topical question and of great interest to not only physicians, but I think to everyone in the field of medicine. Over to Dr. Chawla now.
Sir,
That I
just a
want
minute.
to add one more word. I want to add one word that Dr. Khalilullah was a close friend of my father-in-law, who also belonged to Nagpur. I am also graduated from Nagpur University. And after, so from me, he is more like my father-in-law, because in absence, I lost my father-in-law. He left his physical body. So for me, he is a fatherly figure. And so I have all the memories of Nagpur University, though I was in Wardha, but under the Nagpur University. So let's listen to Dr. Rohan Chawla, and I'll request Rajiv Garg to introduce Dr. Rohan Chawla. Dr. Garg, kindly introduce.
Hello. Mr. Vineet Sood is also on the line, I think now. May I request him to say a few words, Mr. Vineet Sood, before we start the oration. Mr. Vineet Sood has joined, I think.
Morning, everyone. Thank you so much for giving us this honor of being a part of this oration. We feel very touched and very proud that you all remember my father with so much love and affection. And I wish the oration all success. Thank you so much.
Thank you so much, sir. Thank you very much. And now I request upon Dr. Rohan Chawla, who's the Associate Professor of RPA Eye Center at AIMS, to join us. First of all, regarding Dr. J.J. Sood, I personally owe a lot to Dr. J.J. Sood, and he was the one who actually helped me start my career in ophthalmology from Lions Hospital, New Delhi. And he has actually made immense contribution to the coming up of Lions Hospital. And one of my colleagues here, Dr. Dipali Garg, is still working over there, and the department is really flourishing very well in their hospital. Dr. Sood did a lot of work in ophthalmology. I mean, all the community program that was being held in Lions Hospital, all the outreach program was his contribution. And besides, of course, in the IMA New Delhi branch and Lions Club also. So he was really actually a father figure for all of us, and we owe a lot to him. And of course, Dr. Khalilullah, who has been our great professor from GB Pant Hospital. We have great regards for him. Thank you very much, sir, for being here. And now Dr. Rohan Chawla, who will be talking to us. We have brought in the topic to not just include diabetes in the eye, but also as a retinal disorders as an update for the physician. So Dr. Rohan Chawla will be covering about the recent updates in retina for all the physician consultants. Dr. Rohan, over to you. Dr. Rohan has been my colleague at Max Healthcare, and he is, very interesting thing. He is part of the reverse brain drain. So he was in private practice earlier on, and after doing very well in private practice, he had a roaring practice. He was a favorite of all the ophthalmologists, he was favorite of all the patients and other physicians. And then he left private practice to go back to AIMS to follow academics, and he's doing exceedingly well in academics also. Dr. Rohan, he's a gem of a person and a very good ophthalmologist. Over to you, Dr. Rohan.
Thank you, Dr. Dhawan. Thank you very much for such a kind introduction. I hope you can hear me.
Yes, we can. Please go ahead.
And I'm greatly honored to be here in the company of such senior, esteemed consultants, professors, and teachers. And it is a very big honor for me to be presenting this oration. Thank you very much, IMA. Thank you, presidents of IMA and Dr. Dhawan especially. So like Dr. Dhawan said, my main emphasis will be on diabetes and the eye, but I have also included some other advances in retina for what the general physician must know. I'll just start my presentation. Okay. So it's a great honor for me to present Dr. J.J. Sood Oration, and I would be talking on retinal disorders and update for the physician. I have no financial interests. So just a very brief introduction. The eye is like a camera with a system of lenses in front and a sensor behind, like you have in the camera. So when you take an image of the live retina, this is how it looks like. You have the central area, which is the most sensitive, the macula, the optic disc on one side, the yellowish structure, and the blood vessels. So this is what a normal retina looks like. So when should a physician suspect that his patient is suffering from a retinal disorder? So if the patient is complaining of a sudden or rapidly progressing loss of vision, or the patient gives you symptoms like flashes of light or multiple floaters in front of his vision, or a distortion of vision, these could be some symptoms which could suggest that a patient is having a retinal disorder. So like William Osler said, that just listen to your patient. The patient is just telling you the diagnosis. So you see, when we listen to our patients, they might be telling us a lot of things, but it is very important for us to really, from that jargon, take out the important symptoms and give more importance to them and not neglect these. So we will not neglect the symptoms unless we know what we are looking out for. So these are some symptoms which must be given a lot of importance, and they point towards a retinal disorder. So retinal detachment is one of a very devastating disorders which can lead to absolute total loss of vision. So this is preceded by a history of flashes and floaters and a loss of field of vision in one part and then subsequently central vision. And we can now fix it with advances in surgery, but the best results are if the surgery is done within 1 week of the retinal detachment. So this is a wide field retinal image showing you how sometimes the retina can tear in a lot of places in large tears and totally detach from its place. But yes, now with modern surgery, it is possible to fix it, put it back in place, and patients can regain good sight if treated in time. Now, the main focus of today is diabetic retinopathy. Why? Because it is the leading cause of blindness in an age group of 20 to 75. And India, as you know, is now becoming the diabetic capital of the world. And we have an enormous diabetic population at present. The prevalence of diabetic retinopathy in younger onset patients is also quite high. And in type 2 diabetics, up to 21% of the patients would already be having some retinopathy by the time of diagnosis. Now, one thing which can slow it down is a very good systemic control, which is often neglected by the ophthalmologist as well as sometimes perhaps by the patient and the physician. So some facts about it. A diabetes control trial has shown that a 10% reduction in HbA1c reduces the diabetic retinopathy again by nearly 10% and it by 40%. And an 11% reduction also reduces the need of laser by about 30 to 40%. Controlling blood pressure is also very important, and that also can reduce the incidence of diabetic retinopathy by 10%. Both the systolic as well as the diastolic blood pressure have a relation to diabetic retinopathy. So these are some things which must be stressed to the patient other than a control of ocular control. Now, lipid lowering agents such as statins and fibrates both have a role in reducing diabetic retinopathy and hard exudates. And perhaps an LDL less than 100 is something of a reasonable level, although there is always controversy on what the ideal level should be. And even if the LDL level is normal, if you have a patient with extensive hard exudates in the retina, statins have shown to reduce these level of hard exudates in the retina. Managing nephropathy, perhaps early nephropathy with ACE inhibitors also has a role in protecting diabetic retinopathy, and anemia, which adds to the ischemia, should also be managed, which would reduce the ischemia of the retina and progression of diabetic retinopathy. Other parameters like quitting smoking and adding physical exercise also benefit diabetics to a great deal. Now, if the patient has developed diabetic retinopathy, then the next step where we can help the patient is timely screening, catching it early so that we can treat it properly. So this is the WHO recommendation that if it is a type 2 diabetic, then the time of screening is at the time of diagnosis. If it is a type 1 diabetic, then we have some time, but perhaps within 3 to 5 years, the first screening should be done. And if the patient is reaching puberty, then puberty can accelerate diabetic retinopathy. So then again, an early screening should be done. For a known diabetic who's going to become pregnant, every trimester we must see the patient. Gestational diabetes generally does not predispose to changes in diabetes. Now for a physician, now screening is coming to the physician's office. Always you don't need referral to an ophthalmologist. Now there are various devices. I have no financial interest in them, but there are very many handheld devices available where the physician can just dilate the pupil simply by putting one drop of tropicamide eye drop and take a photograph. Some non-mydriatic fundus cameras are also available. And now smartphone imaging is also coming in vogue. Now we've been trying this at AIMS. Now, some of the smartphones have the placement of the camera and the light source very close by so that it acts as a retro illumination, just as we get in a direct ophthalmoscope. This is an iPhone 10. So we just have to put it in live mode and video mode and take it close to the patient. See, the phone is almost touching the patient's mask, and just keep focusing on the dilated pupil, and one would slowly get the view of the optic disc and the macula. So you see, it is something like doing a direct ophthalmoscopy. If you don't have that skill, you can use this. So we can see the optic disc, we can see the changes at the macula, and we can also look a little bit around. So it's not that good, but it's not that bad either. Without any associated lens, just a smartphone we have used. If you apply other lenses, then definitely you can get better images. But this can be used as a screening tool. And for someone who does not know so many signs in the retina, at least you can learn what is normal and what is not normal. So if something is not normal, perhaps it is time to refer the patient early to an ophthalmologist. So this is what is not normal. As diabetic retinopathy progresses, you start getting small red dots, which are hemorrhages. These are mild and microaneurysms. This is mild non-proliferative retinopathy, which can progress, and you can start getting hard exudates, soft exudates. You can even start getting a bleed in the retina, which is a proliferative stage. So from a non-proliferative stage, the disease goes on to a proliferative diabetic retinopathy. So how do these patients lose vision? Once the patient is in a proliferative stage, the patient will develop a bleed inside the eye, obscuring the retina, which is vitreous hemorrhage or a tractional retinal detachment. And in a non-proliferative stage, the retina swells up. There is edema, fluid exudation into the retina, lipid exudation into the retina, and the focusing on the retina will be hampered. This is called macular edema, and that is also a cause of loss of vision. So this is an image of a vitreous hemorrhage. See, the red blood is floating in front. We can hazily see the disc and the vessels. Similarly, the patient is unable to see the world around. And when we get these white fibrous tissue on the retina and it pulls it up, it is called a tractional retinal detachment. Now, this is hard exudates, which I showed you earlier, right at the center, at the macula, which is macular edema. So all these patients are going to lose vision. And today it is possible with medical and surgical management to help quite a few of them. How do we investigate these patients? We do something called fluorescein angiography. We just inject 3 ml of this dye intravenously. And as this dye circulates through the vessels, we take photographs and we can highlight the vasculature. The abnormal vasculature, which are these small white dots, are the microaneurysms, also get highlighted. The abnormal new vessels also get highlighted, and we can get an idea of how to treat these with laser. Another new non-invasive investigation which has come up is optical coherence tomography. This is basically a topographic map of the 10 layers of the retina. It is something like ultrasound, but here we are using light to get these images. So these black spaces are the fluid which is collected in the retina. So we can assess what is the amount of macular edema, how much is the retina being pulled up, tractional edema, and accordingly again manage the patient and follow up the patient. So what do we do? Well, the mainstay of therapy has been pan-retinal photocoagulation for proliferative retinopathy. So once the patient develops these bleed kind of things in the retina, we laser it. These are white laser spots. Laser is like basically we are destroying a large area of the peripheral retina so that we can save the central area. The most of the blood is redirected to the central area and the ischemia of the peripheral retina reduces, and that helps at least to maintain central vision. For macular edema, we have leakages, these macular focal leaks right at the macula. So for macular edema, we can do focal laser, these yellow spots, these laser application right at the macula, sparing just the center. So these would close these focal leaks, and this would also help improve or stabilize the patient. So for proliferative disease, it has been shown that laser can reduce the risk of severe visual loss by about 50% at the cost of loss of a bit of contrast and field. And even in macular edema, it reduces the risk of moderate visual loss. Unfortunately, it rarely improves vision. Now, what has been a game changer today is the introduction of these monoclonal antibodies, which are anti-vascular endothelial growth factor. Now, these agents can now help to improve vision in these patients. Now, the only drawback is that they have to be injected into the vitreous. So we have to do it taking all aseptic precautions. And these agents have a half-life. So in some patients, they would last a month, some patients, they would last 3 months, but then we might require recurrent injections. But they are excellent agents to reduce macular edema and cause regression of neovascularization, which is highly dependent on the VEGF production in the eye. And these can lead to improvement of vision. So as I said, the drawbacks are that the effect is temporary and they require repeated injections every few months. So this is an OCT image. Now the first one is, you see that the retina is swollen up, thickened, and this is before the injection. And once you give the intravitreal injection, you see the good response, how thin and the central contour of the retina is re-established, and it's become almost like a normal retina, and the patient's sometimes does improve even to 6/6. Now, we are also treating them with intravitreal steroids. Now, steroids and diabetes perhaps don't go hand in hand, but I'm not talking about systemic steroids. This is local injection of intravitreal steroids into the eye, which helps by counteracting some inflammation, as well as steroids also have an anti-VEGF action. So they also can help to reduce macular edema and neovascularization, and they have a longer duration of action. But the demerits are that steroids can increase cataract and they can also lead to glaucoma. So these are probably kept as second line therapies, but are also being used now quite frequently for management of diabetics. So just an example, a patient with a lot of hard exudates, this is pre-laser. Now we identified the leaks with fluorescein angiography and did some focal laser. And after a few months, you see there is marked reduction in the hard exudates and normalization of the retinal architecture. Now, this is before injection of an anti-VEGF. You see how angry looking the vessels are. It's a proliferative disease with some edema. And it is after injection. The other image is after injection and following laser. Again, the edema is reduced and the neovascularization starts to regress. Now, today, we cannot have a discussion of healthcare delivery without separating it from economics. Now, we have 3 to 4 anti-VEGF molecules available, and the cost, as you can see, varies quite a bit. And unfortunately, this all is dependent on company marketing and the focus of the companies. They do say that some of the designer new molecules have a longer duration of action, some of them have better efficacy. But so how do we decide which one to prefer? So a recent Cochrane review has shown that at least for diabetic retinopathy, all the 3 anti-VEGF agents are almost equally efficacious. So I think the choice of the anti-VEGF agent lies on the doctor and the discussion between the doctor and the patient. It will depend on the economic criteria, the availability of the drug, and the legal issues. So I just want to say that as a doctor, let us not promote a particular molecule. We should take the patient's clinical condition into account and the other criteria, and then take a combined decision. If the patient is unable to take a decision, then you have to take the decision. But what should not be economically unsound for the patient, because most of these molecules do have a good benefit. Now, other than retinopathy, diabetes can also cause cataract, and performing surgery in a diabetic patient is a little different ball game. The cataract surgery, which Dr. Dhawan might want to talk about, he's a great expert of cataract surgery, should definitely be performed after a good control of diabetes and adequately managing retinopathy first as far as possible, and then going ahead for cataract surgery. And diabetes can also predispose to other things like glaucoma, to vascular occlusion, central venous occlusion, central retinal artery occlusion, which is something like an infarct of the brain, ischemic optic neuropathies, and mononeuropathies, such as a third nerve palsy or a sixth nerve palsy. So all these would also require management. And all of them would are better controlled with a good diabetes control and a good systemic control. To summarize, a successful management of diabetic retinopathy, you require appropriate screening for early detection, a good systemic control, and a judicious use of anti-VEGF therapy, intravitreal steroids, and then followed by supplementation with laser, which can probably make the effect more permanent. For advanced cases, we have vitreoretinal surgery where we can clear vitreous hemorrhage, we can settle retinal detachments to an extent, and at least for patients who are bilaterally blind, give them at least this much vision that they regain mobility and they are no longer dependent on others. So a holistic approach, the cooperation between physicians, endocrinologists, nephrologists, and retina specialists probably would go a long way in the proper management of diabetic patients. Now, I will just touch one other disease, also now increasing in incidence as now the aging population increases in India. So this is age-related macular degeneration. Now here, because the central retina, the macula is degenerating with age, there is loss of central vision. Now what happens is that in the wet form of disease, there is bleeding which occurs under the retina, which will reduce visual acuity. In the dry form of the disease, the central retina starts to atrophy and the photoreceptors start atrophying, and that would also lead to reduction of vision. So this is a photograph of a wet form of disease where you can see these blood spots under the retina and again some exudates. But since it's right at the center, patient loses the capability of central vision. So the patient may not be able to recognize faces, patient may not be able to read properly, though fortunately the patient is mobile because the peripheral retina is okay, peripheral vision is fine. But yes, for those who need the central acuity, that is severely hampered. This is dry form of the disease. These yellow dots you see are drusen and this central area of atrophy. So again, if the central retina is atrophic, patient is going to lose vision. How do we make a diagnosis? It is again by those similar techniques, by a fundus examination and aided by fluorescein angiography and optical coherence tomography. For dry AMD, perhaps we do not have much treatment. We can perhaps give multivitamin supplements in the advanced stages of disease only, which some studies have shown to retard it and controlling hypertension. For wet AMD, again, the mainstay of therapy today is these anti-vascular endothelial growth factor agents, and these have a very good effect in this disease. The only thing is that they have to be again continued for a long time in about 1/3 of the patients. One third of the patients might just respond to few injections. To summarize, summary on the retinal diseases, common ones which we see today: diabetic retinopathy, age-related macular degeneration, and retinal detachment are probably three common ones. For all of these diseases, an early detection is required for appropriate therapy, and the advances in medicine and surgery have made them treatable to quite an extent. Thank you. Thank you very much.
Thank you very much, Dr. Rohan, for a wonderful talk on the subject of retina and covering diabetes and ARMD as a main thing. Yes, of course, in India, due to two factors: the changing lifestyle and increasing longevity, diabetic retinopathy and ARMD have actually increased and almost exploding. So it's very, very important for everyone, not just general physician or ophthalmologist, but everyone to know about these entities and have at least the basic information about them and to be able to manage their patients in their field also properly. So thank you very much. And are there any questions from the audience? If there are any
So
questions,
in oration, we won't like
Oration,
to have
there's no,
questions.
yeah.
all right, sir.
As
Okay.
a customary
Dr.
in
KK and Dr.
oration,
to
I'd like
summarize.
discuss Dr. Khalilullah to give his comments, and then I'll.
I think it was a brilliant presentation of diabetic retinopathy and the current treatment in saving eyesight of billions of people. I think early diagnosis and consultation with the ophthalmologist is mandatory to every diabetic. I would say as a diabetic has to undergo a cardiovascular checkup every 6 months. Whether he is symptomatic or asymptomatic, he should undergo an eye checkup with the ophthalmologist every 6 months and maintain a proper follow-up record and also his eye pressures, I think today the advancement has increased so much that which was irretrievable at one time can be solved at this point of time. And I appreciate Dr. Chawla's presentation. And normally we don't have any questions after the oration. But if the audience has any one or two questions, maybe
I will
Yes.
let me speak out, and then Dr. Kalra can ask. So I just want to add a couple of points. Beautiful presentation. Dr. Khalilullah is a cardiologist. I have a cardiology practice of interest. So therefore, and now I have worked a lot into COVID for the last 1 year. So I want to add few points. The point number one is that diabetes can have macrovascular disease and microvascular disease. All three microvascular disease, nephropathy, neuropathy, and retinopathy, have one thing in common, and that is endothelial dysfunction. So the earlier sign of, therefore, we say if retinopathy is present, we say nephropathy is present. And if nephropathy is present, we say retinopathy is present. So therefore, one is a Jugadu fundus examination, which Dr. Chawla should teach all of us, using the phone and also using a lens, so that we can capture a picture and send it to Dr. Dhawan or to Dipali ji ki bhai consultation le lo, iska bata do fundus mein kya hai. So that's one thing. So we as a cardiologist say that if you have microalbumin in the urine, you presume you also have retinopathy and you also have intima media thickness, which is thickened subclinical atherosclerosis. And if a ophthalmologist says that I have seen retinopathy in you, kindly go and check your microalbumin and rule out cardiac involvement and rule out. And if an endocrinologist says that you are a diabetic, you have a erectile dysfunction, he says you have both retina. So all these microvascular diseases are interlinked. If one is present, presume others are also present. So look for that. And another message for all of us today is very simple: day zero of diabetes. The type 1 diabetes may take 3 or 5 years to develop microvascular disease. In type 2 diabetes, on day zero on the diagnosis, you cannot send a patient back without having a ophthalmology or ophthalmology, nephrology, and neurology checkup and consultation. Dr. Chawla very clearly has said day zero, day zero, day zero. That's a message because we are also live for the public. So the public message is very clear. On day zero of diagnosis of diabetes, rule out microvascular disease, which may be nephropathy, retinopathy, or even neuropathy for that. So that was a couple of comments I wanted to say. And another thing I wanted Dr. Chawla to reconfirm that if you have retinopathy, that's not a contraindication for the vaccine. Because some people will say that I am having a retinopathy, should I take the vaccine? Will the vaccine be harmful to me or not? And the last thing I'm saying is that if I want to prevent all systemic low-grade inflammation, whether it is retinopathy or nephropathy, the basic cause is low-grade systemic inflammation in the adipose white cell in diabetes, which is causing inflammation in the pancreas and in the muscle and other systemic organs. So come back to a non-inflammatory lifestyle and non-inflammatory primordial treatment to treat all three inflammations in the eye, in the kidney, and in the nerve together. Over to Dr. Sanjay Dhawan to take few questions and then have the...
Sir.
Should I just
Hello.
comment on what Sir
No
has said?
questions, please. No questions. Thank
Should
you
I
very
just
much.
comment on what
I will be-
Professor Agarwal has said?
Sir.
Yeah, thank you
Sir.
very much, Professor Khalilullah and Dr. Agarwal, for the comments.
Yeah.
Just to reiterate,
Yeah, I think now
what
I'll
Agarwal
request
said-
Ritu to display the certificate to Dr. Chawla. Ritu, please.
Dr. Chawla, please continue with the comment.
Yeah,
Complete your
sorry.
comment,
Okay.
please. Yeah.
Yeah. Just to reiterate what Dr. Agarwal has said regarding the vaccination, many patients have also asked me not just about diabetic retinopathy, but who have undergone retinal surgery also, that should they take the vaccination? My answer is please go ahead. These are not contraindications for COVID vaccination. So from my ophthalmic side point of view, I have myself taken it, and all of you, please go ahead and take the vaccination. From the physician's point of view, the contraindications might be separate.
Thank you,
Sir,
Dr.
can I
Chawla.
say one line, sir? Dr. Kalra here. Although
Yes.
Dr. KK had stolen my question, I was asking the same thing. I wanted to add erectile dysfunction also, because that is also a marker of endothelial dysfunction.
Yes.
So if those who are having erectile dysfunction, should they also be subjected to retinal examination?
Obviously, on the day one, erectile dysfunction means endothelial dysfunction.
So normally we would have given a memento and certificate in person, but because everything is virtual nowadays, we'll be able to show a virtual certificate right now, and maybe we'll be able to send it across to Dr. Rohan Chawla. So Ritu, can you please display the certificate for Dr. Rohan Chawla? So Dr. Rohan Chawla, thank you very much for gracing the occasion and giving this oration and enlightening us with your wonderful talk. And please accept this certificate on behalf of IMA New Delhi branch and Heart Care Foundation of India.
Thank you very much. Thank you very much for this bestowing this honor.
Thank you.
Next.
Thank you.
Dr. Dhawan.
Ma'am, good morning. कैसे हैं आप?
Good morning. Dr. एक quick question पूछता हूँ आपसे.
अभी पैनल मैडम अभी पैनल डिस्कशन है, उसके बाद उस पैनल डिस्कशन में पूछिएगा.
Okay, thank you, Dr. Khalilullah. Thank you, Dr. K.K. Agarwal. And now I will hand over the mic to Dr. Sanjay Dhawan to conduct the panel discussion. Dr. Sanjay Dhawan, please.
Thank you, sir. Thank you very much. So we have a panel of experts with us who will be talking to us about the recent advances in ophthalmology. And let me start by calling my guests. First of all, Dr. Umang Mathur. Dr. Umang, are you there?
इनको पिन कर दीजिए. रितु जी सबको पैनलिस्ट को पिन कर दीजिए.
Dr. Umang?
Yeah, I'm here. Can you hear me?
Yeah, hi, we can hear you. We can't see you, but.
Oh, I have my video on.
Oh, yes. Now we can, yes. So we can see you also now. So Dr. Umang Mathur is the Executive Director of Ophthalmology at Shaw's Charity Eye Hospital. He's actually Executive Director for the entire hospital. And he's one of the leading cataract, refractive and cornea surgeons of New Delhi. He's had done his training mainly from NDB Prasad Eye Institute after his post-graduation. And he's done tremendous work in the field of ophthalmology, not just cataract, refractive and cornea, but also in the outreach program. So Shaw's Charity Eye Hospital has got a tremendous outreach program and doing great amount of service for the poor and the needy. Dr. Umang, thank you very much for coming on on this conference today.
My pleasure.
Next, we have Dr. Rajiv Bajaj.
Hi, good morning. Good morning, everybody. Can you see me?
We can't see you. We can only hear you.
Video. Hello. Can you see me now?
We still can't see you, Rajiv.
Hello. Is it okay now?
The screen is blank, The screen is blank.
Just give me a minute. Huh?
So Dr. Rajiv Bajaj is also a very senior ophthalmologist. He owns his center in Pitampura, the Bajaj Eye Care Center. He's the director of that center. He is also an expert in the field of cataract and refractive surgery. And I know him for a very, very long time. We were batchmates from Al-Azhar Medical College. We were roommates in the hostel. And so we actually studied together and done all our, not just academics, but all the non-academic stuff together. So he's a great friend of mine. Now? Yes, of course we can. Wonderful.
Thank you. Thank you, Dr. Sanjay. Thank you, IMA, for inviting me at this session. I'm really honored and to be here with you.
Thank you very much. And next we have Dr. Tarun Kapoor. Dr. Tarun? Is Dr. Tarun there?
Yeah, can you hear me now?
Yes, Dr. Tarun. Welcome to the conference today, but I can't see you yet. Yes, I can see you now. Dr. Tarun is a senior ophthalmologist working with me at Max Healthcare. He's a very good human being and a great friend of mine. He did his training basically from Al-Azhar Medical College and Guru Nanak Eye Center and has been working as mainly glaucoma specialist at Max Healthcare. Besides glaucoma, he also does general ophthalmology and cataract surgery. He's a gem of a person and a great human being, as I said. Thank you, Dr. Tarun, for coming on to the conference today. Next, we have Dr. Dipali Garg. Dr. Dipali?
Yes, good morning, Dr. Dhawan.
Good morning, how are you doing?
I'm good, and thank you very much for inviting me, and thank you, IMA. for this wonderful opportunity.
So Dr. Dipali is also from Maulana Azad Medical College. She did her training in Guru Nanak Eye Center, and she is a pediatric ophthalmologist specializing in squint surgery. So we have a pediatric point of view coming from her now. So I think let's get going. So the idea is to have a very, very informal chit chat where I'll be asking questions to the panelists with the purpose of bringing out what is the latest in the field of ophthalmology. Ophthalmology is a strangely or an interestingly very highly technology dependent branch. The reason being that it's a very small organ, and it's a very, very micro thing. We talk and think in terms of microns, not millimeters, but actually we think in terms of microns. So we have to be very, very precise and microscopic, and that necessitates the use of technology in our field. So there have been improvements in the field of imaging. There have been improvements in the field of surgical technique and surgical treatment. There have been developments and improvements in the field of the medical treatment of in ophthalmology. So all this has led to tremendous advances in the past 2-3 decades. Past 3 decades actually has seen giant leaps in the field of ophthalmology, starting in the early 90s when laser refractive surgery came in and phacoemulsification came in. Then the improvements in the imaging which happened in the 2000s in terms of OCT and other modalities. And then the arrival of femtosecond laser in the last decade. All these things have made huge progress in the field of ophthalmology. So starting one by one, let me just start with our guest, Dr. Bajaj. What is the latest in the field of cataract surgery in terms of what surgeries and surgical techniques are happening?
If we see way back in 1989, 90s, we used to perform intracapsular cataract extraction. That it was done using a very large incision was given on the cornea, and the whole lens was extracted. So that method was called intracapsular cataract extraction. And at that time, no IOLs were put in the eye. So patients were entirely dependent upon glasses, thick glasses. You see that old men used to wear plus 12 glasses. So as we gradually moved on from intracapsular, then it was converted. We came to extracapsular cataract extraction, where the incision was a bit reduced, and we start putting implants in the eye. Later on, with the advent of phacoemulsification is a process where a small incision is given, and the lens is divided and extracted through a very small incision, practically 3 millimeter incision. And with the advent of foldable implants, the technique becomes even more better and better. So nowadays we are doing micro phacoemulsification. It's done through 1.8 millimeter incisions, and such lenses are available which go through very small incisions. Then if we talk about lenses, there are monofocal lenses, there are multifocal lenses, there are trifocal lenses, there are toric lenses. So all these things have added to the result of improvised result in cataract surgery.
Great. So talking about the incision part, Dr. Umang, can you just highlight what is the need for reducing the size of incision? What was wrong with the 10 millimeter incision, and what is better with the small incision?
So firstly, smaller incisions leave the eye with better integrity. But practically the main differences of astigmatism, the cylindrical correction that you get post-surgery is more predictable with smaller incisions. So you have a chance to give the patient better unaided vision, quicker recovery. Almost from the next day, the patient is seeing very well. And the need for glasses for distance, especially if you're using monofocal, is minimized. So smaller incisions give more predictable results and leave the eye with better integrity. So that's how the surgery has evolved today.
So actually, in other terms, if you look at the cornea is just about 11 to 12 millimeters in diameter. If you make an incision of say 8 millimeter or 10 millimeter, it distorts the cornea to a great deal, and that is what leads to astigmatism in the thinking, and that hampers the vision, hampers the recovery. Plus, a large incision leads to a very slow healing process, and is very, very prone to leakage, and also being a large portal, more prone to infection going into the eyes. So all these things necessitated the need for the incision to become smaller. And smaller the incision, the more is the better is the integrity, as Dr. Mathur said, and less of the distortion of the cornea. So what else has the phacoemulsification brought in terms of the surgery besides making the incision smaller?
Latest, we have femto lasers in the field of phacoemulsification. Femto lasers, they have made the surgery a bit more specific and precise in terms of some steps and.
So, Dr. Mang, do you think that TS femtos actually made a huge difference over and above the phacoemulsification?
So as of now, I think only a very small subset of very hard cataracts that it would make a big difference. To the patient, I don't think right now it has reached a point where it gives anything special. Because most of the surgery is still performed by the same phacoemulsification and the same kind of lenses. But I think in a few years' time, these lasers are going to do much more. And that's how the surgery is going to proceed. As of today, I don't think they offer anything spectacular, but that's how the trend is going to be.
So for the sake of the audience, let me just say that femtosecond laser, or the so-called blade-free laser, is a new technique, a new tool that we use in cataract surgery, whereby all the incisions which were so far being made by blades or manually are done by a laser. So there are three aspects to it. One is the science. So scientifically speaking, it's a big advancement. And second is the tool. It's a great tool to have. But third is the application and its result. In terms of application, it has same application that we use with other tools. In terms of results, so far, there's not much of a difference in the results seen whether we do a manual microphacoincision surgery or a femtosecond surgery. That's what Dr. Umang Mathur is trying to highlight to you. But yes, it's a great tool. It's a great scientific advancement, and in future, I'm sure that it will have a great application also. So the other aspect in cataract surgery which has evolved is the lenses, as Dr. Bajaj was saying. So Dr. Umang, what has been the advances in the lenses?
So, as Dr. Bajaj mentioned, apart from monofocal lenses, we have lenses that can to some extent improve your intermediate or near vision. I wouldn't say they've arrived totally and they're not applicable for everyone. Depending on the patient's lifestyle, you have to choose the right candidate for it. But for people who like to have spectacle-free vision, today you have these trifocal, extended depth of focus or multifocal lenses. And there's small nuances between them, but essentially a lot of them help you with the range of vision without glasses. Also, we discussed about astigmatism. So today, lenses are available to correct your cylindrical power as well. And so you get better spectacle-free vision with these lenses. I think there's a lot of science going on in improving materials of lenses. And so today's lenses cause less inflammation. They cause what we call as posterior capsular opacification, which is a little intensification of the capsule that has got reduced. So there's a lot of improvement, and of course, smaller incisions that these lenses can go through. I think there's been a lot of change in lenses that has come up in the last few years. And it's a good time to be an ophthalmologist and to be a patient. I think the results are far more predictable. You have more range of instruments to work with.
Correct. Dr. Bajaj would like to add something about the lenses part.
Yeah, one really has to choose according to the patient's lifestyle. Most of the lenses, patients we implant are monofocal implants. And if we see that the patient has a high astigmatic power in the eye, then toric lenses are certainly an edge ahead of the monofocal in the monofocal category. And trifocals, according to my experience, which I have implanted in last in couple of years, if you choose a correct patient, they really work very well. Sometimes the results are amazing. Patients are absolutely free of glasses.
Right. So that's true. That's correct, actually. And again, to recap for the audience, when we do the cataract surgery, we remove the natural lens. So there's a basically a refractive deficit in the eye, and we have to implant an artificial lens to correct the refractive error left behind by the removal of the natural lens. So far, we were implanting monofocal lenses, which would normally adjust for far vision, and for the near vision, patient would need to wear glasses. But with the arrival of newer lenses, which are bifocal or trifocal or extended depth, there is no need for near glasses also. So the patient can actually see the far and the near both very, very clearly. To counteract a pre-existing astigmatism in the eye, we have got toric lenses. So the advancement in the field of lenses has been on three fronts. Number one, the material, as Dr. Monk said, that material has improved. It is more biocompatible material, induces less inflammation, so patients with uveitis and all are better implanted with those lenses. It causes less of a pacification of the posterior capsule, the so-called after cataract. Now, also, the design has improved in terms of physical shape. It's able to mold and go through small incision and fit very well inside the eye. But also optically, the improvements have been tremendous. Even the monofocal lenses are now what is called the aspheric lenses, which provides much better contrast and sharpness of vision, which is in need of the hour these days. People drive at night time, people lead a very active life outdoors. So those lenses have a much better visual quality. Then with multifocal, there's a range of vision which is clear without the glasses. So actually the lenses, as Dr. Mang rightly said, makes a huge difference from the point of view of the patient and the result. A technique makes slightly lesser difference. So if switching from microfocal to femto is only very small increment in terms of quality of vision, but changing the quality of the lenses has a huge impact on the patient's visual quality. Dr. Rohan's talked about cataract surgery in diabetics. Dr. Rohan, can you elaborate on that part? That what is the requirement that when we're planning cataract surgery in a diabetic patient, what is the role of, say, an endocrinologist or a physician in controlling the diabetes? How should be the control? How much before it should be in control? What are the safe sugar levels? And for how long it should be in control?
Before that, Dr. Dhawan, I would just like to add a comment to the previous discussion, which you have very nicely summarized. But for the general audience, I think the level 1 advance for them is that when they develop a cataract, it means that their lens has become opaque. So the level 1 advance is just a safe removal of that lens and implanting in other lens. So that is just level 1 advance, which has gone to a very great extent. And then the level 2 advance is that in the same surgery, if you want, you can also get your glasses removed or rather your refractive error corrected. So then the patient has to decide, depending on various things, whether level 1 advance is sufficient or they can add on the level 2 advance and go ahead for the entire package.
Correct, that's right. So these days, cataract surgery is not just cataract surgery, but it's become a cataract refractive surgery is what is being implied here.
Yes.
Yes, Rohan.
Yes. And for the second question about the diabetes, so definitely a well-controlled diabetic patient is one which should be taken up for any surgery. But in our scenario, probably all patients we will not be able to get who have an HbA1c less than 6.5 or 7. So maybe an ideal control is never possible. But yes, also do not try to have a control in say a day or two just by pushing some insulin and something and then operate the patient. So at least give a few weeks to the patient and have him controlled. It is generally said that if a random blood sugar is less than 200, then probably the white blood cell function is not that hampered. So depending your random blood sugar is constantly above 200, then definitely the white blood cell function is hampered, and that might predispose the patient to infections. So that can be taken off as one cutoff. And well, yes, the ideal is a fasting less than 120 and a postprandial less than 170. But even if I would say a random is less than 200 and your patient is decently controlled, not just that you've controlled him for a day or two, you can probably take up the patient for surgery. And other than that, also examine the retina first. If the retina, there is retinopathy, then if the cataract is not too dense, manage that first, either with lasers or intravitreal injections, and then take up for cataract surgery. And if there is edema and you cannot manage it otherwise, do cataract surgery, but in the same sitting, you can give the intravitreal injection. So that will take care of both.
So we always focus on the pre-operative control of blood sugar, but we tend to forget the control after the surgery, which is a very, very critical period because 2 to 6 weeks is the time when the eyes are highly predisposed to infection. So what would you say for that? For how long sugar should be in good control?
Yeah, so this safer surgery has generally reduced the healing period. So probably the corneal wounds and all take not more than 3 to 4 weeks to heal. So yes, the first month post surgery is most critical, where you should have a very good control of diabetes. And yes, thereafter also maintain it. But the perioperative period is a few weeks before surgery and a month after surgery.
So the message is not to push a patient for surgery by quickly controlling the blood sugar in a day or two. I always suggest the patient to have it controlled, well controlled 1 to 2 weeks before the surgery, and maintain that control for at least 4 to 6 weeks after the surgery. There have also been some other subtle advances in the field of cataract surgery in terms of the anesthesia, the medical treatment, or say they were not needing the eye patch or bandage on the eye. Dr. Bajaj, what would you say about that?
Yes, certainly. Earlier, we used to give infiltration anesthesia. That is to infiltrate the surrounding tissues of the eye. So it made the surgery painless. It causes the immobility of the eye. Nowadays, what we do is just put a topical anesthetic drops a couple of minutes before the surgery, and then we are able to carry on the procedure effectively. So that is called topical anesthesia. So we have changed from a retrobulbar anesthesia where the injection was given behind the eyeball to peribulbar anesthesia where the injection was given just along the eyeball, to subtenance anesthesia, and now it's a topical anesthesia. So we are very comfortably able to do cataract surgery, that is phacoemulsification in the peribulbar anesthesia.
So, Dr. Mongu, what would you like to add to this, in terms of medical treatment associated with cataract surgery?
Yeah, so I mean, in terms of anesthesia, especially, I think patients can get back to work immediately within a day or two. Eye is quieter, you can start the drops immediately. So the patient doesn't need to remain bandaged and patched. So patients are generally far at ease with the surgery. And with phacoemulsification now, the surgery, because you're not touching the other tissues, the eyes are very quiet. And with just some topical drops, there's no need for any oral medication after surgery. Just with topical drops, the patients can very comfortably recover from the procedure. So overall, in fact, today we don't even stop blood thinners before surgery with topical anesthesia. They don't need to stop any of their other medication because it's largely a geriatric disease. And so there are patients with comorbidities that come. But with cataract surgery today, you really don't need to stop their systemic medication before surgery because virtually bloodless and very low risk of bleeding. So we stop, we no longer stop any of the blood thinners before surgery.
Yeah, that's correct. And actually, the surgery has become far more comfortable for the patient. The duration has become much shorter. So most surgeries are completed within 10 to 20 minutes of time. Most of the time, a patch is not required on the eye. Patient goes back home the same day. Patient can resume the work the next day. No oral antibiotics are required. No oral medication is required. We just need to put some topical eye drops in terms of antibiotic and steroid for about 3 to 4 weeks time. So it's become far more comfortable with early rehabilitation. Since we're not touching other tissues, there's no risk of bleeding, so we don't need to stop the blood thinner. Anticoagulants, of course, may have to be stopped for a few days. And what is your view about stopping the drugs for prostate, the alpha agonists?
I think with experienced surgeons, even that is generally not a big problem. So you have to take care of it during surgery. Sometimes the iris becomes floppy. But if you craft your incisions properly and you're careful, I think generally, and you have other instruments available today as hooks and things that can help you manage those situations as well. So it's something that can bother a surgeon during surgery, but most cases, I think you can manage without really changing the patient's medication.
Well, I feel that if they are stopped at least a day before surgery and not taken on the day of surgery, it helps in that way.
Yeah.
So the message for other specialists that yes, you can always put it in your prescription that whether you would, are you comfortable with the patient stopping your medication or not. In case you're comfortable, then we can stop it for, say, a few days before and restart the next day. In case you say that no, that if this patient requires continued medication, then we can manage without stopping the medication also. So this is a message for the other specialists and all. After the cataract, another important topic is the glaucoma, and we have glaucoma expert Dr. Tarun Kapoor with us. Dr. Tarun, what have been the advances in glaucoma in the last 2 decades?
See, glaucoma has changed a lot in the sense that the diagnostic part, the treatment part, both have changed significantly. I still remember in the Nanakai Center when we started the glaucoma unit, field charting was done by Jerem Screen, then we went on to Goldman. Today, these are things which the ophthalmologists have probably never seen. We just use automated perimeters for visual field analysis. Same way with the advent of the UCT and GDX and HRT and all these equipment for the optic disc analysis and the retinal nerve fiber layer thickness assessments. So with these advents, the diagnostic part has really changed tremendously. And as far as the treatment goes, I mean, medical, there are 3 parts. We know medical, the lasers, the surgery. The medical treatments earlier only probably just 2 or 3 medicines, pilocarpine, timolol, beta blockers, and phenylephrine was available. Today we have prostaglandin analogs, and you have so many other medicines, and there are 2-3 newer medicines which are coming in. These, medicines which provide nitric acid, nitric oxide radicals, which help to increase the outflow. Then you have the these the row vasopressors. They help these, and you have great combinations coming in. So today we have a huge armatorium of medical treatment. So the amount of surgery that we used to do has also gone down because we are able to manage a large number of cases just with medical treatment. And surgically, things are changing. Still, I feel that trabeculectomy with or without mitomycin remains the basic surgical treatment, though newer things like shunts and these valve devices and all are coming in, but still, I think trabeculectomy cannot be ignored at this stage. But I think in the near future, with proper development of these shunts and valves, things are going to change tremendously.
So that's glaucoma is like diabetes. That once you have glaucoma, it's always a case of glaucoma, and you need to always monitor the eye pressure. You need to always take the drugs on a regular basis and monitor the damage or the effect of glaucoma on the eye in terms of visual fields and optic nerve fiber layer changes. So the patient compliance is extremely important. That is the reason why the newer drugs, which have to be instilled less frequently, are helping in patient compliance. They achieve better control of the eye pressure round the clock because the eye pressure is at its peak early in the morning when the patient is asleep at about 4 o'clock or so. So the newer drugs actually blunt out that peak in the morning. And many times patient needs to put the drops only maybe once or twice a day and to achieve a good control of glaucoma. We have better diagnostic modalities in terms of automated perimetry and OCTs and HRTs, which can monitor the damage or the effect of glaucoma in a much better way. So these have been the advances. Are there any advances in the field of lasers in glaucoma?
See, lasers, peripheral iridotomy is a very important procedure by laser for especially narrow angle glaucomas. And argon laser trabeculoplasty was tried, but it worked in some patients, it didn't work in some patients. Nowadays, selective laser trabeculoplasty is being done, which has probably a little better response. And that is the basic newer field.
Correct. So So just to
But
recap.
one thing I want to, one thing I
Yeah.
want to emphasize is in a case of glaucoma, the patient and the doctor both have to realize that it's a multifactorial thing. It's not just one that, okay, the pressure is high or the disc is like this. You have to take everything into consideration. There has to be a full workup. I mean, you have to have the vision, the eye pressure, the visual fields, the retinal nerve fiber, all of them have to be, correlated. And only then you can make a diagnosis. And I still feel that even after all this that we have, glaucoma still remains the most overdiagnosed as well as the most underdiagnosed disease as far as ophthalmology is concerned. I mean, there is lots which needs to be really developed here.
Correct. Actually, the borderline cases can be really very, very tricky, and we can either err on the either side. So to be on the safer side, we always keep a very high suspicion of on these cases. We monitor them closely. And again, for the sake of audience, the diagnosis of glaucoma usually may not be possible in one single sitting or at one point of time. You may have to observe and the patient over a period of maybe months to a couple of years to be able to confirm or rule out the diagnosis of glaucoma, especially either in the borderline cases or the tricky cases where it's a normal tension or a low tension glaucoma. A clear-cut case of glaucoma can be diagnosed in one go, can be put on treatment immediately, but not the borderline cases. So I don't think that the
And one more point I would like to highlight to this audience is that there is a subset of glaucoma known as low tension or normal tension glaucoma. See, the concept of glaucoma immediately even the other doctors and even the general population correlates high pressure is going to be high. But there is a subset where the pressure may be normal. So you have to look out for those cases and you have to convince the patient that yes, you have glaucoma even though your eye pressure is in the normal range.
So next, let us talk something about to our bacha ophthalmologists, the pediatric ophthalmologists. So what have been the advances for the kids in the past few decades, especially in terms of squint surgery or in terms of amblyopia and other things?
So Dr. Dhawan, most importantly, I think it's the awareness which has risen remarkably. We passed through a phase where you had patients or parents thinking that squint was a thing which had to be handled in adulthood. And lazy eye was often missed because we didn't take the patients at the right time for a regular pediatric eye examination. And now I feel that even it's basically coalescing between the pediatricians and the ophthalmologists. So even they refer the patients to us for an early eye examination, which is mandatory for us to catch it and nip it in the bud. As far as squint is concerned, see, squint is not only about cosmetic rehabilitation, it's functional rehabilitation as well. So for the general practitioner also to realize that to restore binocular vision and stereopsis, we have a window period where we'll have to operate the patient if required early. For constant squints, with the advancement of pediatric anesthesia, we have gone to operating them under 1 year of age. And for intermittent squints, it's around 4 to 5 years of age where we intervene if the frequency of squint is high. Also, it's become very, very useful for the patient and the parents because, when you're dealing with pediatric patients, you have the parents who play a very major role in it. So having minimally invasive squint surgery, just like we have minimally invasive cataract surgery, adjustable sutures, phonics-based incisions makes the eye rather quiet. Most of the times I'm not patching the eye of a pediatric patient because the children get affronted, the parent gets affronted with both the eyes being patched. Rehabilitation is rather quick. By the second or third day, the child is good enough to be resuming normal activities. And the only thing you have to caution them about is a little inflammation in the eye or a little redness, which is persistent. So it's very important to stress that we are looking at an overall rehabilitation of the child. It's psychological, it's emotional, it's functional, it's cosmetic. So all 4 things go hand in hand. As far as lazy eye is concerned, of course, patching or occlusion therapy remains the backbone. And there is no substitute. Other things are mainly adjuvants. So adjuvants we usually use if you're catching these patients late. But if you are able to catch this child in time and we institute the correct format of occlusion therapy, I'm sure we are able to revert a lot of these cases of amblyopia.
Correct, very right. Yeah, very rightly said. And so basically, in terms of pediatric ophthalmology, the changes have been advanced have been more in terms of principles of treatment, not in terms of technique or technology. So the principle of squint surgery have changed. The principle of amblyopia therapy has changed. There's more awareness, and pediatricians have become more aware. So pediatricians and ophthalmologists, especially pediatricians and pediatric ophthalmologists, are collaborating in a much better way, which is also a message for the day for everybody else.
So संजय जी मुझे 2 मिनट बोलना है क्योंकि ये we are also live on social media and this is likely to be viewed by thousands of people. I would like now you to take over in Hindi and come back to public messages from each one of them, whether it is a repetition. तो starting from दीपाली जी, public को squint के बारे में कौन सी 5 चीजें हैं जो मालूम होने चाहिए? 5 messages ले लिए, then you can come back to your discussion because otherwise ऑडियंस चली जाएगी जो पब्लिक वाली है. स्क्विंट में पब्लिक को, सो डॉक्टर संजय धवन टेक फ्रॉम ईच वन ऑफ देम 5 पॉइंट्स ऑन देयर रिस्पेक्टिव सब्जेक्ट कि जनरल पब्लिक को स्क्विंट के बारे में क्या मालूम होना चाहिए इन हिंदी. 5 पॉइंट्स.
सो दीपाली,
स्क्विंट में हम भेंगापन कहते हैं और भेंगापन में हमें ये जानना बहुत जरूरी है कि ये सिर्फ एक देखने में भेंगापन होना एक अलग चीज है, उसके साथ साथ आपकी दोनों आंखों को साथ इस्तेमाल करना जिसे हम बायनोक्युलरिटी कहते हैं, ये बहुत जरूरी है. तो जब भेंगापन हो तो उस समय हमें आंख का टेस्ट करवाकर ये देखना कि किसी एक आंख में नजर कमजोर तो नहीं है, दूसरा ये भेंगापन हमेशा रह रहा है या यह भेंगापन कभी कभी रह रहा है, उससे हम कितनी जल्दी ऑपरेशन करते हैं उसकी वो उस बात पर निर्भर है कि हमारा भेंगापन कांस्टेंट है, मतलब हमेशा रहता है, या भेंगापन कभी कभी रहता है. तीसरी बात यह है कि भेंगापन में कुछ छोटा या बड़ा नहीं होता. हम ये नहीं कह सकते जी उसको थोड़ा सा ही स्क्विंट है या कुछ ज्यादा स्क्विंट है. स्क्विंट का मतलब या भेंगेपन का मतलब है कि दोनों आंखें साथ काम नहीं कर रही, साथ हिल नहीं रही. तो चाहे वो थोड़ी मात्रा को हो चाहे ज्यादा मात्रा को हो, भेंगेपन का ट्रीटमेंट होना ही होना है. और जितनी जल्दी हम इसका इलाज करेंगे उतने अच्छे हमारे रिजल्ट.
जो मेजर सवाल दीपाली जी आता
के साथ लेजी आई
दीपाली जी, जो सबसे मेजर सवाल आता है कि मेरी लड़की को थोड़ा सा भेंगापन है, शादी नहीं हो रही, तो क्या उस स्टेज में कुछ किया जा सकता है? क्योंकि अभी तक तो ध्यान ही नहीं दिया. अब जब सारे लड़के बोल रहे हैं लड़की को तो स्क्विंट है, हम शादी नहीं करेंगे, तो आज की डेट में क्या सर्जरी या कोई चीज करके की जा सकती है ताकि उसकी जिंदगी बन जाए, शादी हो जाए?
बिल्कुल की जा सकती है सर. मतलब भेंगेपन का इलाज हर उम्र पर किया जा सकता है और भेंगेपन का हम आंख सीधी तो हम कर ही देते हैं, वो तो हमारे हाथ में है. लेकिन अगर नजर कमजोर रही हो बचपन से तो हम उस नजर को शायद वापस ना लौटा सकें पूरी तरह, लेकिन आंख तो हम सीधी कर ही देते हैं, चाहे वो
कम से कम आंख हम सीधी कर सकते हैं, विजन जैसी है वैसी ही रहेगी. उसके साथ में डॉक्टर संजय धवन, नाउ यू आइडेंटिफाई समबडी फॉर काला मोतिया. चारों में से किससे पूछो?
डॉक्टर तरुण क्या बताएंगे कि काला मोतिया क्या है और इसके लिए क्या करना चाहिए?
काला मोतिया में और सफेद मोतिया में दोनों को मोतिया क्यों बोलते हैं? व्हाई डू वी कॉल देम एज काला एंड व्हाई डू वी कॉल देम एज सफेद मोतिया?
काला मोतिया उसको कहते हैं कि काला पानी जिसको कहते थे पहले, तो आंख का प्रेशर बढ़ जाता है और उसमें काला मोतिया का जो सबसे इम्पोर्टेंट चीज ये है कि हर इंसान को जो 40 साल के ऊपर चला जाता है, आई का जो चेकअप होता है उसके अंदर उसको आई का प्रेशर जरूर चेक कराना चाहिए. और दूसरी चीज ये है कि दवाई डलवा के पीछे के पर्दे की जांच, जिससे हम ऑप्टिक नर्व या ऑप्टिक डिस्क जिसे कहते हैं, उसकी जांच होनी चाहिए. तो हर इंसान जिस 40 साल के बाद ये 2 चीजें तो अपने रेगुलर चेकअप में साल में एक बार या 2-3 साल में एक बार ये चेकअप होना चाहिए. दूसरी बात ये कि जो भी डायबिटिक पेशेंट हैं, जो मायोपिक पेशेंट है जिनका माइनस का नंबर ज्यादा है, उनमें ये ज्यादा देखा जाता है. तो इसलिए उन लोगों को भी अपना ये प्रेशर और जो ऑप्टिक डिस्क चेकअप जरूर होना चाहिए. काले मोतिया के पेशेंट को साल में एटलीस्ट एक बार ये टेस्ट जो हम कहते हैं कि फील्ड चार्टिंग है, ओसीटी है, ये सारे टेस्ट रिपीट कराने चाहिए कम से कम साल में एक बार। और फॉलो अप जो है, कम से कम अगर प्रेशर कंट्रोल्ड है, सब कुछ ठीक चल रहा है, तब भी 2-3 महीने में एक बार आई का चेकअप जरूर होना चाहिए। हम लोग आजकल चश्मे का चेकअप कराने ऑप्टोमेट्रिस्ट के पास चले जाते हैं, लेकिन उसमें हमारा आई का प्रेशर और फंडस एग्जामिनेशन या ऑप्टिक्टिस्ट एग्जामिनेशन रह जाता है। तो ये चीज बहुत इंपॉर्टेंट है, लोगों को समझना चाहिए। चश्मा तो चाहे आप वहाँ चेक करा लें, लेकिन एक आई स्पेशलिस्ट के पास जाके ये 2 चीजें जरूर चेक करा लेनी चाहिए। तो मैसेज ये जरूर जाना चाहिए सबको।
सिर्फ पूरी दुनिया में अगर मेरे को सबका काला मोतिया का प्रेशर चेक करना है, 30 साल से ऊपर की पॉपुलेशन, तो मेरे पास करीबन 100 करोड़ लोग हैं जिनकी उम्र 30 साल से ज़्यादा है। इतने मेरे पास रेटिना स्पेशलिस्ट तो है नहीं कि वो सबका प्रेशर चेक करें। क्या जुगाड़ू तरीका है कि हर डॉक्टर क्लिनिक पे प्रेशर चेक करके उन्हीं लोगों को रेफर करे जिनका प्रेशर ज़्यादा है और बाकी लोगों को रोक दे। तो को जैसे डॉक्टर रोहन चावला जी ने जुगाड़ू बताया, मैं उन्हीं के पास आ रहा हूँ, वैसा प्रेशर के लिए भी कोई जुगाड़ है क्या जीपी के लिए?
जीपी के लिए तो प्रेशर का कोई इतना जुगाड़ नहीं है। हम डिजिटल प्रेशर कहते हैं, लेकिन वो हम ऑफ्थल्मोलॉजिस्ट फिर भी हम लोग, क्योंकि हम इतने केसेस देखते हैं, हम अंदाजा लगा लेते हैं डिजिटली कि आई का प्रेशर हाई है या नॉर्मल है। कितना है वो तो नहीं पता चलेगा, लेकिन हाई या नॉर्मल रेंज तो पता चल जाती है। लेकिन दैट इज नॉट इनफ। तो या तो ये है कि ऑप्टोमेट्रिस्ट के पास जो जिसे कहते हैं वो नॉन कॉन्टैक्ट टोनोमीटर्स जो हैं, वो इतने अवेलेबल हो सब जगह कि वो चीज चेक हो सकती है, क्योंकि उसमें आपको एक आई स्पेशलिस्ट की जरूरत नहीं है। तो नॉन कॉन्टैक्ट टोनोमेट्री जो है, दैट अगेन विल हेल्प।
उसमें क्या होता है नॉन कॉन्टैक्ट टोनोमेट्री में?
नॉन कॉन्टैक्ट टोनोमेट्री में एक बेसिकली मशीन होती है जिसमें एक एयर प्रेशर पफ से आता है,
ये तो
और
है
उसमें
मशीन हो गई
रीडिंग आ
ना।
जाती है।
टोनोमेट्री
हाँ।
क्यों आप लोगों ने हटा दी? हम लोग बचपन जब हमारे मेडिकल कॉलेज में हमें टोनोमेट्री, हम लोग तो लाइन पे लगा के लोगों के चेक करते थे, वो क्यों हटा दी गई? कॉन्टैक्ट टोनोमेट्री
हटाई
क्यों
नहीं
हटा
गई
दी?
है, हटाई नहीं गई है, दैट इज स्टिल अवेलेबल। अभी भी हमें कई बार जब जैसे वार्ड में जाकर किसी का प्रेशर चेक करना है, तो शॉर्ट टोनोमेट्री से ही हमें करना पड़ता है, और कोई तरीका नहीं होता। तो ये नहीं कि हटा दी गई है, बट क्यों बेटर टेक्निक्स, एप्लेनेशन टोनोमेट्री और ये सब ज्यादा एक्यूरेट हैं और ज्यादा वो साइंटिफिक वो हैं, तो इसलिए ज्यादा यूज होते हैं। ये नहीं कि हटा दिया गया है, बट उससे बेटर टेक्निक्स अवेलेबल हैं, इसलिए आई स्पेशलिस्ट उन टेक्निक्स पे ज्यादा रिलाई करते हैं।
सो रोहन
सिर्फ
जी, मेरे को
सिर्फ
रेटिना का पिक्चर लेना है और मोबाइल का इस्तेमाल करना है, तो कौन सा लेंस बीच में लगाऊं, क्यों बेटर हो जाए?
सर जैसे आपने कहा जुगाड़ू टेक्निक्स, शुरू तो ये जुगाड़ से ही हुए हैं, लेकिन पूरी कोशिश ये है कि जैसे 100 करोड़ लोग रेटिना स्पेशलिस्ट के पास नहीं पहुंच सकते, तो कुछ ना कुछ टेक्निक बने जिससे एटलीस्ट कुछ तो इमेज मिले रेटिना की, और उसमें से जो हायर रिस्क पे हैं वो जल्दी रेफर हो जाएं। तो लेंसेज इसमें है कि हम तो 20 डायप्टर्स का एक बड़ा लेंस है, 20 डायप्टर्स का लेंस आंख पे रख के और उससे एक फिक्स डिस्टेंस पे अपना मोबाइल फोन रखें तो बहुत अच्छी फोटो आ जाती है। बट 20 डायप्टर्स लेंस महंगा है, पर हम आजकल कोशिश कर रहे हैं, ये क्लिप ऑन लेंसेज आपको अमेजोन और जूम वगैरह पे भी मिल जाते हैं, तो सम ऑफ द क्लिप ऑन लेंसेज कैन ऑल्सो वर्क। बट जैसे मैंने आपको दिखाया कि अगर आपके फोन में जो लाइट सोर्स है और जो कैमरा है उसके बीच में डिस्टेंस बहुत कम है, 3-1 मिलीमीटर तक है, तो वो रेट्रो इल्यूमिनेशन की तरह काम करता है। तो उसमें आप बिना किसी लेंस के भी एटलीस्ट ऑप्टिक डिस्क और मैकुला देख सकते हैं।
20 डायप्टर का लेंस या 28 डायप्टर का लेंस कितने का आता है?
सर आजकल 7-1 हजार का आएगा।
Not very costly for a GP to buy it.
Not at
So
all.
I'll all my program officers who are watching this program, please buy. I will make sure डॉक्टर रोहन चावला को मैं पकड़ के लाऊं और एक जूम के ऊपर में आप लोगों को ट्रेनिंग दो, and I'll make sure at least 1000 GPs join, और हम आप सब लोगों को ट्रेनिंग दें कि घर में बैठ के किस तरीके से आप 7000 इन्वेस्टमेंट इज नॉट ए बिग इन्वेस्टमेंट फॉर ए GP। ये स्टेथोस्कोप भी 12,000 का है हमारा कार्डियोलॉजी में। सो 7000 इज नॉट ए बिग इन्वेस्टमेंट। अगर हम उनको सिखाएंगे कि डायबिटीज के ऊपर में किस तरीके से आप 20 और 28 डायप्टर का लेंस लेके आप रेटिना की पिक्चर को ये सारे ऑप्थेल्मोलॉजिस्ट के पास भेज सकते हैं, इनको भी दुख नहीं होगा, इनको भी इनकी कंसल्टेशन फीस मिल गई, पेशेंट को जाना आना बच गया, और जीपी ने अपना पेशेंट भी भेजने की जरूरत नहीं है, उसने पिक्चर ली एंड ही चार्जेस फॉर द कंसल्टेंट फी एंड ही पेज टू द कंसल्टेंट। इससे होगा कि अगर पेशेंट को ट्रीटमेंट लेना है वही पेशेंट रेफर होंगे, नॉर्मल वाले पेशेंट्स को आप इलेक्ट्रॉनिकली वर्चुअली आप ठीक कर पाएंगे। राजीव जी,
सर इसमें एक वर्ड ऑफ कॉशन यही मैं कहना चाहूंगा कि हाँ ये थोड़ा जुगाड़ू ही है, इसमें कंप्लीट एग्जामिनेशन नहीं है, तो इसमें
मेरा मतलब सिर्फ रोहन जी एक ही है, नॉर्मल एबनॉर्मल।
यस सर, नॉर्मल एबनॉर्मल बस।
क्वेश्चन इज नॉर्मल एबनॉर्मल, आपने बोला एबनॉर्मल आपको रेफर कर दिया, आपने बोला नॉर्मल हमने रेफरल बच गया। So we are not doing it for a follow-up. Follow-up has to be done by the ophthalmologist. But when we screen normal, abnormal, that should be done by the GP. Because अगर हमारे को आज की डेट में 10 करोड़ डायबिटिक हैं या नए डायबिटीज डायग्नोज हो रहे हैं, ऑन डे 1 आपने देखना है तो जुगाड़ ही करोगे, और उसके बाद में एक बार रेटिनोपैथी हो गई तो हमको जीपी का रोल खत्म हो गया। Then follow-up has to be done by the ophthalmologist. So we are only talking about screening of cases so that more and more people are picked up. So आज की डेट में डे 0 में लोग स्कोप ही नहीं है। अगर मैं डे 0 के अंदर में जीपी को ट्रेन करूं कि डे 0 में आपने ये चेक करना है, तो अर्ली केसेस पकड़ में आएंगे। अर्ली केसेस, मेरा तो नया कैंपेन है, इफ योर सीआरपी इज मोर देन 1, check for all microendothelial dysfunction disorders, because the first criteria will be self non-self reaction and that will be CRP will be more than 1. So coming back to राजीव जी ये जो कैटरेक्ट में अभी जैसे सब लोगों ने पहले कहते थे जल्दी कराओ, और जब ये लॉकडाउन आ गया तो बोले वेट करो, क्या चक्कर है ये, कब तक वेट कर सकते हैं?
मेरा ये मानना है कि
सबने बोला, पहले बोलते थे बाईपास कराओ, इसमें बोला कि रुक जाओ, पहले बोलते थे अर्जेंट है एंजियोप्लास्टी, अब कहते थे रुक जाओ, पहले कहते थे तुम्हारा कैटरेक्ट आज नहीं कराओगे तो कल तक फट जाएगा, अब हम कहते हैं वेट करो। तो एक्चुअल में क्या है, कब कराएं कब ना कराएं?
सर मेरा ये मानना है कि जब पेशेंट को प्रॉब्लम हो रही हो अपने फंक्शनल विजन में काम करने में, उसको टीवी नहीं दिखता, वो ड्राइव नहीं कर सकता, वो पढ़ लिख नहीं सकता, वो देख नहीं सकता, जब पेशेंट को प्रॉब्लम हो रही है तो उसे कैटरेक्ट सर्जरी करवा लेनी चाहिए। ये पहले वाला कॉन्सेप्ट था कि मोतियाबिंद पका कि नहीं पका। आज की डेट में ऐसा कोई कॉन्सेप्ट नहीं है कि मोतियाबिंद पका है या पका हुआ नहीं है। पहली वाली टेक्निक्स पकने तक की इंतजार करने से ज्यादा अच्छी होती थी, आजकल की टेक्निक्स उस स्टेज में ज्यादा अच्छी होती जब पेशेंट्स को प्रॉब्लम हो रही होती है। तो टेक होम मैसेज यही है कि अगर आपको प्रॉब्लम हो रही है, अगर कुछ कैटरेक्ट्स ऐसे होते हैं जो पके हुए नहीं होते लेकिन वो रात को पेशेंट्स को ड्राइव करने में बहुत प्रॉब्लम क्रिएट करते हैं, सो इन दैट केस मेरे हिसाब से अगर पेशेंट को प्रॉब्लम हो रही है, वन शुड गो गेट एग्जामिन्ड एंड गेट हिम ऑपरेटेड।
सो उमंग जी, मेरा एक सिंपल सवाल है, कब मैं ड्राइविंग कर सकता हूं और कब नहीं? कौन कौन सी ऐसी कंडीशंस हैं आई की कि मेरे को उसको ड्राइविंग सर्टिफिकेट नहीं देना? क्योंकि आम जनता यही पूछना चाहती है ड्राइविंग के ऊपर में कि मैं ड्राइविंग करूं कि नहीं करूं।
अनफॉर्चुनेटली इंडिया में रूल्स बहुत चेंज नहीं हुए हैं। जैसे इंडिया में आपको कलर विजन पे अभी बहुत रिसेंटली ही अलाउ किया है, नहीं तो योर ड्राइविंग लाइसेंस आपको मिलता नहीं था। बट यूएस में अगर आप जाएंगे तो आपको इफ यू आर कलर डेफिशिएंट यू कैन गेट अ ड्राइविंग लाइसेंस। सिमिलरली यहाँ पे ग्रेड्स ऑफ ड्राइविंग लाइसेंस नहीं है कि इफ यू आर वन आइड इन द यूएस यू कैन गेट अ लिमिटेड driving license for driving in the city but not on the highway because your depth of vision gets affected. So if you have only one functional vision, one functional eye, in India you can be denied a driving license. But अगर आप functionally बात करें तो जैसे cataract है, उसमें कुछ लोगों को काफी दिक्कत हो सकती है ड्राइविंग में, स्पेशली ग्लेयर की वजह से। at night headlights will trouble you. So if you have a significant cataract and for some reason आप ऑपरेट नहीं कर रहे तो ड्राइविंग अवॉइड करना चाहिए। अगर आपको मैक्युलर डिजेनरेशन है, जो डॉक्टर रोहन चावला ने अभी काफी उस पर एलैबोरेट किया था, उसमें भी ड्राइविंग में दिक्कत हो सकती है। ग्लोकोमा में आपकी फील्ड ऑफ विजन अगर बहुत सिवियरली अफेक्टेड है then also it is not right to drive because आपको साइड की व्यू नहीं दिखेगा and you can have an accident. So some of these visions, and of course if your vision for whatever reason अगर आपका चश्मे से vision improve नहीं कर रहा है 6/12 से better in your good eye, then you should not be driving. So बहुत सारी vision related issues हैं जिसमें driving avoid करना चाहिए because you won't be safe on the road.
I've been told so many million RTA road traffic accident takes place in India every year. Do you have any data? How many of them may be due to vision disorders?
Yes, I think truck drivers पे काफी studies हुई हैं.
नहीं उमंग जी, मैं सिंपल चीज बोल रहा हूँ कि if you can give us a data, अगर हम आई चेकअप को कंपलसरी कर दें, स्ट्रिक्ट कर दें और उसको इम्प्लीमेंट करें, तो कितने एक्सीडेंट बच जाएं, तो आई कैन मूव द सुप्रीम कोर्ट एंड गेट यू द ऑर्डर. अगर हम इसको अभी मैं सवाल नहीं बोल रहा, आई एम ओनली ट्राइंग टू से इफ ऑल 6 ऑफ यू आर कन्विंस्ड दैट कि आई चेकअप जो हमारे यहाँ पे होता है, जो 200 रुपए दे के आप सर्टिफिकेट लेते हो, अगर वो एक्चुअल में चेकअप हो और आई विजन के कारण से अगर प्रॉपर है, तो इतने एक्सीडेंट बच सकते हैं. So this can be a very good effort on our behalf to do that.
Sure, sir. I'll get back to you on this.
Yes. So coming back to Sanjay, last question, then I hand it back to you. संजय, मेरे को ये बताओ, कंजक्टिवाइटिस पब्लिक के बाद में मेरी आंख लाल हो गई, मेरी लेफ्ट हो गई, मेरी राइट हो गई, मेरी दोनों हो गई, आंखें लाल हो गई हैं. तो आंखें लाल होने के लिए पब्लिक को क्या करना है? कब उनको समझ में आए कि ये एडिनो वायरस है कि कौन सा वायरस है, या कब उनको पता लगे कोविड तो नहीं है, कब उनको पता लगे कि ये वायरल है कि बैक्टीरियल है, कि आंखें आ गई हैं लोगों का, और क्या प्रिकॉशंस लें?
आंखें आना या आंखें लाल हो जाना कब जो कॉमनेस्ट कारण है वो है कंजक्टिवाइटिस, यानी कि इन्फेक्शन ऑफ द कंजक्टिवा. कंजक्टिवा जो है आंख की सरफेस लेयर है, और इसमें आंख लाल हो जाती है, आंख से पानी आता है, आंख से डिस्चार्ज आता है, स्टिकनेस होती है, हल्का सा पेन डिस्कम्फर्ट होता है, कुछ केसेस में विजन में भी कमी आ सकती है. कॉमनेस्ट कॉज जो कंजक्टिवाइटिस का वो है वायरल इन्फेक्शन. कौन सा वायरल इन्फेक्शन है डिफरेंशिएट कर पाना बहुत मुश्किल है. देखा गया है कि कोविड के केसेस में भी कंजक्टिवाइटिस होती है, एंड अक्सर कंजक्टिवाइटिस से ही पेशेंट प्रेजेंट करता है, और हमने पाया है कि लेफ्ट आई थोड़ी सी ज़्यादा इन्वॉल्व है कंपेयर टू द राइट आई, बट इट में स्टार्ट विद द लेफ्ट आई एंड गो ऑन टू द राइट आई लेटर ऑन. सो अगर कंजक्टिवाइटिस है तो इसे इग्नोर नहीं करना चाहिए, अपने ऑप्थेल्मोलॉजिस्ट से मिलकर उसकी जांच करानी चाहिए, प्रॉपर ट्रीटमेंट लेनी चाहिए. ट्रीटमेंट जो है सिंपल है, बिकॉज मोस्ट केसेस जो कंजक्टिवाइटिस के हैं दे बिकम ओके ऑन देयर ओन इन 1 to 2 weeks टाइम. But to prevent complication, we may have to give some antibiotic eye drops or some soothing agents to the eye. Cold compresses, washing the eye with clean water can be helpful at home in the early cases. But
अमेरिका में जो रिफ्रेश आई ड्रॉप्स अवेलेबल है उसमें पॉलीसॉर्बेट 80 है. इंडिया में कोई ऐसी ड्रॉप है जिसमें पॉलीसॉर्बेट 80 है?
I'm not aware. Among, would you know that?
क्योंकि ये बोल अभी हम सारे लोग देख रहे हैं कि कोविशील्ड और कोवैक्सिन में पॉलीसॉर्बेट 80 है, and polysorbate is like polyethylene glycose simultaneously. So अमेरिका में they are doing refresh eye drop challenge test, कि ड्राइनेस के लिए आंख में देखते हैं, अगर एलर्जी हो रही है तो बोले कि तेरे को वैक्सीन से भी एलर्जी होगी, जुगाड़ू टेस्ट. तो क्या कोई ऐसा आई ड्रॉप है?
We have refresh tears available in India also. Refresh tears, refresh liquid gel.
पॉलीसॉर्बेट नहीं दिख रहा मेरे को उस वाले के अंदर में एज ए इंग्रेडिएंट. अगर कोई आप लोग देखिए कहीं पर भी आई ड्रॉप्स में जिसमें पॉलीसॉर्बेट 80 है, तो एक जुगाड़ू टेस्ट है कि पॉलीसॉर्बेट 80 वाली आई ड्रॉप्स में अगर आपको डालने पे जलन होती है तो आपको वैक्सीन नहीं लेना. आई एम ओनली कमिंग बैक विद ए जुगाड़ू टेस्ट विद दैट. आई हैंड इट ओवर टू डॉक्टर संजय देवन टू कंटिन्यू योर नॉन पब्लिक मीटिंग. सो आई थॉट कि बीच में ये 10-15 मिनट पब्लिक भी इसको एंजॉय करेगी. थैंक यू.
Thank you, sir. There is a very, very nice break from in a different way, in a very, very interesting way. हमें हिंदी में बोलना आना चाहिए और हमें पब्लिक को भी एड्रेस करना आना चाहिए. इस तरह की मीटिंग्स होनी चाहिए कि हम पब्लिक के लिए कर सकें. So coming back to the topic, we had talked about the pediatric ophthalmology. Another important aspect where a lot of development has happened in ophthalmology is the field of refractive surgery. And we have two very good refractive surgeons with us, Dr. Umang Mathur and Dr. Rajiv Bajaj. Dr. Umang, what have been the advances in the past few decades in the field of refractive surgery and where we are now?
Yeah, you're right. Refractive surgery, we've had a lot of advances in the last 3 decades. I think while we were doing a post-graduation, people were getting radial keratotomy at that time, which were incisions on the cornea. But it was, again, very unpredictable. Lots of issues with the vision post-surgery. And with the advent of excimer laser, initially with PRK and then LASIK, I think today we have a lot of precision in on our hands. And I think over time, we've learned what are the limits of this procedure and where we should do something like what we, for very high numbers or thin corneas, we might implant a lens called implantable contact lens, ICL. And then within LASIK, again, there are improvements with what is known as commonly as blade-free LASIK, with femtosecond laser, where the flap of the cornea is made by a laser, a femtosecond laser. And so that has made it even more precise and safer for the patient. So I think the quality of lasers has improved, glare, contrast sensitivities with the current nomograms have reduced. So for a very wide spectrum of refractive disorders today, these procedures are available. And I think it's one of the commonest procedures performed on the human body today.
Great. Yes.
That's why millions are getting it done.
Yeah.
And I think as ophthalmologists, we feel more confident today in touching normal eyes, that you can make a patient's life, much better without glasses. So those who are interested with refractive surgery today, I think most ophthalmologists would be quite confident in advising it and getting very predictable results today.
That's true that, the refractive surgery is no longer a cosmetic surgery. It actually is a vision enhancement surgery, and there's been a lot of advances. So again, basically for the sake of the audience, in refractive surgery, we basically alter the curvature of cornea or the contour of the cornea. In olden days, we used to give radial cuts or the so-called radial keratotomy, but those are no longer done. We've got now lasers to do that part, no? So we use lasers to reshape the cornea. Earlier on, it was happening on the surface of the eye in the form of PRK. Then we started lifting up a layer on the flap and doing it under the flap. Now we also go into the depth of the stroma in the form of something called smile and remove a lenticule from there. So this is how we reshape the cornea by alter its curvature. Dr. Bajaj, you've been doing the new technique of smile. What is different in smile compared to PRK and LASIK?
See, SMILE is an acronym. Its full form is Small Incision Lenticule Extraction. So a so-called lenticule in the shape of a lens, shape of a convex lens right now, is made intrastromally inside the cornea at a depth of, say, at least 120 microns beneath the surface of the eye. And that lenticule is created by laser itself. It's a machine called Visumax. It's created by femtosecond laser. And that lenticule is approached through a very small incision given at the periphery of the cornea, say around 2 to 3 millimeters. And we separate the lenticule and take out the lenticule intact itself. So the curvature, which was changed earlier using a technique called LASIK, the same procedure, the same effect on the curvature of the cornea is given by the lenticule extraction. So this technique is called SMILE. The advantages of SMILE over the conventional LASIK technique is it is a flapless technique. Pehle cornea mein we used to create a flap, lift the flap, do the laser and put the flap back. So the number one advantage of small incision lenticule extraction is it is a flapless technique. All other techniques were flap-based techniques. This is a flapless technique. The other advantage is that since we are not cutting any flap, we are not severing the nerves. जो nerves and cornea में periphery से enter करती हैं corneal sensations के लिए, we are not cutting those nerves. So this worldwide surveys have been done that it leads to lesser dryness, lesser post-operative dryness in the eyes. Third, and the biggest advantage of SMILE, which has been found in the latest studies worldwide, that it is a more biomechanically stable technique performed on the cornea. Biomechanically stable का मतलब ये है कि अभी तक देखा गया है कि some patients they develop post-operative ectasia. Ectasia is caused to weakening of the cornea, weakening of the corneal biomechanics. The cornea tends to start bending if it becomes too thin, especially in a certain set of patients. So this weakening effect of the refractive laser vision refractive procedures on the cornea is found to be less in SMILE as compared to other laser vision correction procedures. So these are the three main advantages of SMILE.
So basically, for the sake of the audience, we have got different tools now in the form of PRK, in the form of LASIK, in the form of SMILE. Each has got its own application. In all three of them, we basically reshape the cornea by removing the tissue. So we end up leaving a thinner cornea at the end. But there is yet another form of refractive surgery technique where we don't remove a tissue, we actually implant a lens over and above the natural lens of the eye, the ICL or the implantable columnar lens, as Dr. Umang said. So that is the other techniques that we use, but that's mainly for higher refractive errors. No? There are some minor variations in these different tools, some minor indications, and as Dr. Bajaj said that, some biomechanical advantage, some studies show advantage, some other studies do not show much advantage. But the bottom line is that we have a whole range of tools and techniques to treat the refractive error. And now the latest advent is also the arrival of presbyopic LASIK. So far, in earlier days, we would correct the refractive error only up till the age of 40 years of age. After 40, when the patient would have presbyopia, we would kind of raise our hand, we would say we can correct only the distance number, not the near number or the near addition. But now it's even possible to correct both the distance and near. Of course, there are the applications are very specific. You have to be very, very careful in selecting the right kind of patient. But it is possible to do those things. With ICL implantation, we can treat very, very high levels of myopia, more than -10 or so, which were not amenable to correction by LASIK or other laser refractive surgery. Now we can correct them with implantation of ICL. We in an older age group where we cannot do LASIK or where we cannot implant ICL, and patient has got age-related changes in the lens, we can actually remove those lenses and implant multifocal lenses. So something called presbyopic lens exchange is also an option. So bottom line is that the whole gamut of tools and options has increased, and in most cases, the ophthalmologist is able to provide a good, viable refractive solution to the patient. Another important topic for which I would like to ask Dr. Rohan Chawla is the case of ROP. And, so the kids who are born prematurely and are treated with high concentration of oxygen, they do develop problems in the retina. So Dr. Rohan, what has been the recent advances in that field?
Yes, as Dr. Dhawan has said, that this is a problem of premature children, and this is becoming now a huge problem in our country with the advancements in the nursery management. So we are now able to save more and more premature children, but unfortunately, quite a few of them are landing up with this blinding disorder, and this leads to a lifetime of blindness. So it is something which we need to catch early, and if we are able to catch it early, treat early. And I would go a step further and say not just catch early, also try to prevent it. So the new nurseries which have come up, if you adopt good oxygen related practices, if your alarms are not set at a very high level, if your oxygen saturation is maintained around 90 or 92 or maybe even less, then the incidence of ROP definitely goes down. So I can say from my personal experience itself, I have worked at Max and I have worked at AIMS. And at both these places, we have rarely seen live sight-threatening ROP. We have seen ROP and we have treated it with lasers, but the kind of ROP which goes into retinal detachments, we have not seen, because probably at both these hospitals, good practices are being followed. Whereas I have seen patients coming from various nurseries where even the screening has not been done, or even if the screening has been done, very advanced ROP is developed. So number one step is good nursery practices and less oxygen to these babies. Step two is a program to screen these children on time. So today we are having a lot of lawsuits because the public knowledge is also increasing. And if you have a child who is going blind and they read up about ROP and they know that the ROP screening was not done, it is going to be a huge problem for that hospital setup. So an ROP screening is a must, and a timely screening. And if we do timely screening, we can manage it with laser therapy to a great extent. And in some advanced cases, now we are even doing this same anti-VEGF injections. And the cases which come very late, at least stage 4, we are able to salvage with surgery. Stage 5, we do it, but it is almost like a trial sort of surgery. So the advances are catching it early, preventing it prior to that, and managing it with screening and laser. So I think this is something which the pediatricians need to know, and we need to adopt good practices regarding ROP.
Yeah, so basically pediatricians and any specialists need to collaborate well with the ophthalmologists now. My last question is to Dr. Umang Mathur. If Ramata, can you come online, please? I can't see you. So, cornea is another field in which a lot of progress has happened in terms of the surgical technique and the tools and how we manage the corneal disorders and corneal diseases, especially the cornea transplant. And earlier on, we used to do a full thickness cornea transplant. Now it is possible to separate various layers and do a layered transplant. Only a specific layer where the pathology lies can be transplanted with much better result. I think, Dr. Umang? Dr. Mung is doing a lot of work in the field of corneal surgery and corneal transplant. Somehow, I think he's not able to. Dr. Mung, are you there? I think he's probably lost connection. He may join us back in a moment. So, the femtosecond laser, which is we use in both the cataract surgery and refractive surgery, is also used for the cornea surgery. And the cornea, earlier on, as I said, that the full thickness needed to be transplanted, which would be associated with the risk of graft rejection, graft failure, distortion of the cornea, astigmatism. Now it's possible to just transplant the innermost layers. Because in most cases, it is seen that it is the inner layer of the endothelium and the Bowman's membrane which is actually affected. So it's possible to transplant just those layers or to treat the superficial layers also. Sometimes an opacity in the cornea is limited to only the superficial part. It's possible to ablate that opacity with the help of exam laser. So all these advances are happening in the field of cornea surgery also, which has led to much better results. Dr. Mung, are you back or not yet? So with that, we come towards the end of our discussion. If the audience have got any question, please feel free to raise your hands, and I think so. Dr. Mung is joining us back. Yeah, Dr. Mung. I think Dr. Mung.
Yeah, sorry, I got locked out.
Yes, yeah. So we were kind of expecting you to talk about cornea, and
Yeah.
I was just mentioning to the audience that cornea is another area where a lot of advances have happened in terms of cornea transplantation and cornea surgery. And you have doing a lot of good work in this field. Can you just elaborate on that?
Yeah, so I think the first thing in cornea is, I think we are in a very happy position as far as the way eye banking has progressed in the last decade. There was a time just about 10 years back when we didn't have enough tissue to operate. So in eye banking across the country, there are at least about 8 or 10 eye banks, barring the COVID time, that have started collecting tissue over 1,000 per year. So because of that, now tissues are available much better in number and in quality than what it used to be. And I think this audience is important for for eye banking, because as physicians, as doctors, whenever we have an opportunity where there's a death that takes place, I think if a doctor can talk to the family and talk about eye donation, makes a big difference. And there's a universal number 1919, which goes to eye banks, whichever the nearest eye bank will contact the family and take the process further from that. So one is the availability of tissue, which today is much better than what it used to be, but still we are short by over 1 lakh per year. In cornea, again, from penetrating keratoplasty, which was a full thickness transplant only, today we are moving to component surgery where we can do lamellar transplants. So if you have only the inner disease problem, like you have some conditions where the endothelium of the cornea, which is the innermost layer, which gets affected, sometimes after cataract surgery or with Fuchs dystrophy. Today, we just replace that layer with DMEC and DSEC with no sutures virtually on the surface, much better outcomes in vision, as well as lower risk of rejection. If you have a stromal anterior disease, like in keratoconus, we can retain the patient's endothelium, so the risk of rejection becomes negligible, and the patient's cornea will remain clear for his lifetime. So also lasers are being used for cutting the cornea. I wish they were more popular than what currently they can do, but there are lots of newer changes that are coming in the techniques. Also, stem cell work has been done extensively on the cornea. In fact, ophthalmology has been in the forefront of stem cell use across any discipline. And so there are diseases like Stevens-Johnson syndrome or chemical burns, where the stem cells of the that populate the surface of the surface epithelium get affected. These used to be considered hopeless cases earlier. Today, we can restore their visions with stem cell grafting. So in cornea, there are lots of new changes that are happening, apart from, of course, the refractive surgery that happens on the cornea. Lots of therapeutic new advances have come up in the last decade, which now have given hope to a lot of hopeless cases. And with better availability of tissue, we are able to surgically correct them.
So actually, that is the most important message Dr. Umang conveyed, that we as ophthalmologists, we are not dealing with mortality and we are not dealing with terminally ill patients, but all of you specialists and GPs are dealing with patients who are terminally ill, who are, or dealing with the death. And at that point at the moment of tragedy, it's very difficult for young people in the family to even broach the subject of cornea transplant. Either a senior person in the family talks about it, or a physician who is, a family physician who is helping the whole thing. If they start discussing or talking about the subject of cornea transplant, it is much better received by the family at that moment of tragedy than by anybody else. So though some big hospitals got grief counselors, but this sort of grief counseling can be started by the caring physician also. Yes, Dr. Umang, you were saying something.
Yeah, so absolutely. I think we as physicians have a big role to play. Also, we have professional counselors in a lot of major hospitals who talk to the family at that time. I've left a phone number in the chat box. I would request everyone to save that number. That's an iBank number. So whenever you have a situation where, as doctors, you come to know about a death that's happened, please give a call to this number and we'll do all the counseling and connect to the families, motivate them, and also make the eye donation possible.
So let me read that number out for everyone. It's 9650-300-300. I repeat, 9650-300-300. In addition to the centralized iBank number 1919, which Dr. Umang talked, if anybody calls up 1919 from landline, it goes to the nearest iBank, and the team may be available. For this number 9650-300-300, you can actually avail the grief counseling help also. So again, it's an appeal to everyone that if you are in touch, whenever you are caring for a patient who is terminally ill, do gently bring about or open the subject of eye transplantation to the family. Many times you'll find that the young people in the family, the junior members of the family, are really willing and wanting to do that, but are not comfortable starting this subject. So when the doctors talks about it, is taken in a much better way. Right. So I'd like to thank all my guests over here. But I think there are a few questions which are there. One hands are raised. Dr. Mohan.
Yeah.
Mohan Kalra.
Dr. Dhawan.
Yes, sir.
What a wonderful talk and message for the eye donation. I wanted to convey to the audience that there are at least 10 eye drops containing polysorbate 80. Refresh Tear in India also contains polysorbate 80. Others are Tear Plus, Opticure, Isotine, Flogel, Flogel Ultra, Osmo Drops, and also Itone. So there are all having polysorbate 80. So we can check for the sensitivity if we want to rule out.
Fantastic. मैं इसमें बताता हूँ, polysorbate 80 is the only thing which is allergogenic in the vaccine. In the Western form, it is polyethylene glycol. In Covishield and Covaxin, it is polysorbate 80. Polysorbate दो प्रकार का आता है, 80 and 20. So polysorbate 80 is the only thing which can cause anaphylaxis. So this is what I am recommending it, that पॉलीसॉर्बेट 80 वाली आई ड्रॉप्स डाल के देख लो, अगर लाली आती है तो फिर आपको कोविशील्ड से एनाफिलैक्सिस होगी। सो ये आप लोग भी इसको प्रमोट कर सकते हो इसके अंदर में। और अगर उनको आती है तो दूसरा हम लोग क्या करते हैं कि इसी आई ड्रॉप से आप स्किन टेस्ट, स्क्रैच टेस्ट भी कर सकते हैं to find out whether you are allergic or not. Or you can also do a intradermal test with the polysorbate 80. We have 2 patients of anaphylaxis in India. We had 1 death of anaphylaxis in India. So therefore, we all ophthalmologists should promote that polysorbate 80 sensitivity because polysorbate is present in these vaccines, both the vaccines.
Dr. Jain, you had a question in the beginning, I believe.
Very good information. I was not aware of it.
Yes, I was also not aware of that. It's a very, very good,
very relevant
thing, which is a relevant thing. Yes, I know.
डॉक्टर कालरा, जो आपने जो वर्क किया है, कौन-कौन सी के अंदर में है आई ड्रॉप्स में पॉलीसॉर्बेट?
सर, रिफ्रेश टीयर प्लस, ऑप्टिक्योर, आइसोटाइन, फ्लोजेल।
एक सेकंड। टीयर ड्रॉप्स एंड
रिफ्रेश टीयर,
ऑप्टिक्योर,
आइसोटाइन, आइसोटाइन,
हाँ,
and iTone also, Calodine, Ocumoist, all have this polysorbate.
Practically we can tell the general statement कि किसी भी आई ड्रॉप में चेक करो, अगर उसमें पॉलीसॉर्बेट 80 लिखा हुआ है और अगर आप वो ड्रॉप्स लेते हो और आपको लाली आती है, नॉट ज्यादातर, कई लोगों ने मुझे फोन किया कि मेरे को इरिटेशन हो रही है। अगर आपकी ड्राई आईज हैं तो अगर आप रिफ्रेश टीयर डालोगे तो हल्का सा जलन होगी, दैट्स नॉर्मल। There has to be a redness to call it as a anaphylaxis or a allergy happening after 15 minutes. Yes. This was taught to us by Dr. Monica Vasudev. She is an allergic specialist in US. I brought her in my show and she said that कि जिनको जो 23 वाला अगर आपको निमोनिया का वैक्सीन लगाया उसमें भी पॉलीसॉर्बेट होता है, बहुत सारे वैक्सीन्स में पॉलीसॉर्बेट होता है, तो पॉलीसॉर्बेट वहां से आपको पकड़ में आता है एनाफिलैक्सिस होगी कि नहीं होगी। Go ahead. Kindly sum up, Dr. Sanjay Dhawan.
So that brings us towards the end of our panel discussion. Yes, Dr. Jain, please go ahead.
Regarding macular edema, when the person goes to the retinal specialist, they advise them OCT and give them the intravitreal injection. Now, this is repeated every month. Now, are there any guidelines? It happens that, yes, a person has the injection and settles down and find out by doing is OCT.
So let me
are there any symptoms the patient should look forward?
Let me revisit Dr. Jain's question. She is a medical officer in charge in IFCO. इनको सैंक्शन करना पड़ता है पैसा, तो शी बेसिकली वांट्स टू नो कि ओवर यूज तो नहीं हो रहा, कब होना चाहिए कब नहीं होना चाहिए, क्योंकि लोग इनके पास जब तक ये साइन नहीं करेंगे आपको पैसा नहीं मिलेगा। इसलिए ये सारे डॉक्टर्स पूछना चाहते हैं कि असली में गाइडलाइंस क्या हैं। ऐसा तो नहीं है कि इफको को आप जा रहे हो और एक BHEL के इफको के पेशेंट हैं तो वहां पे आपको नहीं भी देना है तो देना, ये इनका बेसिक सवाल है, ये पूछेंगे नहीं, इसलिए मैं इनकी तरफ से पूछ लेता हूँ।
हिडन सवाल है सर। यस, सो डॉक्टर रोहन चावला इज द एक्सपर्ट ऑन दिस नाउ।
Yeah, ma'am. So that is a very relevant question because these injections are required again and again, but unfortunately they are required again and again. So and it also becomes disease specific. So like in age-related macular degeneration, the general recommendation is to first give 3 at a 1 month gap, and then you can give on treat and extend basis. आप OCT करिए, अगर उसमें fluid आ रहा है तो लगाइए, नहीं आ रहा तो 2 हफ्ते और extend कर दीजिए, फिर OCT करिए, नहीं आ रहा तो इस तरह से हम पीरियड 4 वीक्स से लेके 8 वीक्स to 12 वीक्स तक ले जा सकते हैं। And in diabetic patients, first injection and then the second injection, it is not necessary to give the next month. It depends on the OCT and the response. If the response is good, आप wait कर लीजिए, the half life is about 6 weeks, so the patient may require injection after 2 months or 3 months. So it will have to be tailored for the patient, but only there will be 1/3 subset of patients जिनको 3-4 लगेंगे, उसके बाद और नहीं लगेंगे। 2/3 of the patients में लगेंगे ही लगेंगे बार बार, till we have something which has a longer duration of action or some implant sort of thing, जिसमें स्लो रिलीज हो एंड बाद में और ना लगाने पड़े. लॉट ऑफ वर्क इज
लगते ही
गोइंग ऑन
रहते हैं, रेगुलरली लगते ही रहते हैं इंजेक्शन. But डॉक्टर साहब, are there any symptoms? Now OCT, how often of OCT should be done with the patient? Should be advised that if you have these symptoms, you should come to me so that I can get your OCT done. Or OCT should be done on a regular basis.
सिम्टम तो
Any
फॉल इन
symptoms,
विजन
the
नहीं होगा.
patient.
सिम्टम वुड बी फॉल इन विजन या डिस्टॉर्शन ऑफ विजन. बट एक बारी जब डिजीज डिटेक्ट हो जाता है तो समटाइम वी डोंट वांट द सिम्टम टू कम, because patient might have the symptom and he might wait for a week and 10 days and it might worsen. So इसलिए regular OCT is also one of the parameters. People are even moving on to home OCT monitoring in the West. So OCT has become quite an important tool which might be required to be repeated 6 weeks or 8 weeks.
6 weeks. Okay. Thank you so much.
So in other words, I'll also ask Dr. Rohan, what is the end point of treatment for these cases, or there's no end point?
Like I said, 1/3 of the cases will respond very well and they will stop throwing back the edema, and probably some of them with good systemic control and some of them because of the genetic makeup. So if the fluid is not coming back, if the bleeding is not coming back, we stop them. But then in those cases where every 2 months or so up vision fall हो रही है या OCT पे फिर से fluid is coming back, we will have to give them. So at present it is sort of a non-ending treatment. Even with the better molecules, but the better molecules, some of them the duration might be longer. So instead of 2 months, you might be able to stretch it to 4 months, but still we might have to give them.
So
any new molecule that has come up now? I know of Accentrix, Lucentis has gone up to the market. Now it's mostly the Accentrix that is being given. Any other new molecule has come recently?
So there is a VEGF trap molecule, which is trade name is Eylea, and then there is a newer molecule brolucizumab, which has also come up. So 2 are already in India and some others are in the pipeline. And the main aim of these
Eylea and
brolucizumab.
Kindly repeat. Eylea and
brolucizumab. So but like I also mentioned in my talk, आप तो reimburse कर देंगे, but उनका क्या जिनका reimburse नहीं होता, तो जिनका reimburse नहीं होता उनके लिए जो cheaper molecule है वो भी उतना effective है, और it should not be shunned, and rather we have to work towards getting it approved by the drug controller of India.
So Dr. Agarwal, we need your help in this part, that there are cheaper molecules like Avastin, and which is not approved for intravitreal use by the government of India, by the DGCA. If you can help us get that approval, it will be a big help to not just ophthalmologists, but to the entire public at large who needs these injections repeatedly.
Get me a group of 15-20 ophthalmologists. I will call the DCGI in a meeting, in a virtual meeting with all of you.
Right, sir.
I'll present a case to him, understand the difficulties. So I'll speak to him anytime. We can come back for a discussion. He can call his experts who are on that. और अगर उनके यहाँ पे कोई limitations हैं, we are ready to file a PIL in the High Court or the Supreme Court.
Thank you, sir.
No problem. See, any issues, there is a procedure. For any issue, there is a procedure for getting the work done. So raise those points. There should be collective consciousness of the no other ophthalmologist should challenge that. ताकि कोई controversy ना हो. If there is unison amongst ophthalmologists on a particular point, I'll make sure in 3 to 6 months the work is done. So I know the procedure how to do it. There is a standard procedure for getting the work done, as long as we can show it as a science. So please bring that issue to me. I will involve so there has to be either an association or collectively people from, even if I get 5 people from East, South, North, West, Central, who are prominent ophthalmologists, if they sign a document, this needs to be done. Yes, it is possible to get it done in 3 to 6 months' time.
Thank you, sir. Thank you very much. And this brings us to the end of the session. I'd like to call upon Dr. Hemant Saluja, who is the Joint Secretary of our branch, to give a final vote of thanks to everyone.
Thank you, Dr. Sanjay. Thank you, everybody in the audience and the eminent speakers and Padam Shri Dr. K.K. Agarwal, sir. It has been a real educational discourse of recent advances in ophthalmology, and I'm sure everybody listening to the conversation, to the discourses, to the questions, and wonderfully answered questions by all the eminent authorities. It has been a real pleasure and a scientific feast. क्वेश्चंस ऐसे भी थे जो पब्लिक के लिए रेलेवेंट थे, जो हमारे स्पीकर्स ने हिंदी में आंसर किए, जो डॉक्टर अग्रवाल ने पूछे थे, उनसे इस सेशन की रेलेवेंस और बढ़ जाती है। और जैसा कि सर ने सजेस्ट किया कि एक सरोगेट, एक जुगाड़ू तरीका है कोविशील्ड या कोवैक्सीन में जो पॉसिबल एलर्जेंस है उनको देखने का, जो कि पॉलीसॉर्बेट 80 आई ड्रॉप्स में होता है या न्यूमोवैक्स वैक्सीन में होता है, उनसे अगर किसी को एलर्जी होती है तो वो एक तरीका निकाल सके। और बहुत सारे ऐसे नए एवेन्यूज सामने आए हैं, इट हैज कम टू द लाइट दैट अ लॉट ऑफ things can be done to improve ophthalmology so that it becomes affordable, it becomes within the reach, and especially the lens option of as suggested by doctor who said that 28 diopter or 20 diopter, and I'm sure 7,000 or 7,500 rupees is not a big investment, as Dr. Agarwal said, for any GP to give a value added service to his or her patients he's or she is serving. Thank you very much, audience. Thank you very much, eminent speakers. Thank you, doctors, for being there, for sparing your time. And it's been a real scientific feast. Thank you all.
So if Dr. Vanita is here, call her for to close the meeting. If she happens to be here, then he must close the meeting. And thank you, Vinit ji. And
thank you, everyone.
Yes, Rajiv. Rajiv can, I'll pin Rajiv. I'll pin Rajiv here.
Hello.
And so Rajiv,
actually I'm in a bus, so we not be able to communicate right now. Thank you, everyone.
Thank you, Vinit ji. Thank you, Garima ji, and all other.
I'd like to thank everybody for a wonderful and a very informative session. Thank you all. Thank you so much.
So we were live on the multiple media. We'll send you the clicks, and at least 1,000 people, minimum 1,000 people will be might have attended this program. The number may be much higher than that. Thank you very much.
Right. Thank you so much. Thank you.
Thank you.